See when you press it, the red light, that means it's on.
Okay, good morning. I'm calling this public oversight hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, February 2nd, 2026. The time is 9:31 a.m. Today is part one of two for the performance oversight hearings on the Department of Behavioral Health. This morning, we'll only hear from public witnesses. Dr. Barbara Bazaran, the director of the Department of Behavioral Health, and her team will appear before the committee on Wednesday, February 4th at 9:30. Rest assured that Dr. Bazaran and her team are watching and listening today, and hopefully they'll try to respond to some of the concerns and issues that are raised. The Department of Behavioral Health, or DBH, provides prevention, intervention, and treatment services and supports to children, youth, and adults with mental and/or substance abuse disorders, including emergency psychiatric care and community-based outpatient residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth's Hospital, the district's public inpatient psychiatric facility. DBH engages in important and challenging work, grounded in the conviction that the district residents can recover from mental and substance abuse disorders. DBH strives to help them lead healthy, happy, and successful lives. The committee did send written pre-hearing questions to DBH, and we might reference those materials today. If anyone watching would like to see the materials, they can be found on the council's hearing management system website. I don't see any of my colleagues, but if they join us, I'll certainly turn to them for an opening statement. We're going to move to our witnesses. I just want to review the testimony guidelines for today because we do have 58 individuals who would like to provide testimony. And I can't be here all day because someone's in this room after us. So, everyone will have 3 minutes to testify. We'll give you a nudge when your time has expired. There are clocks here on the Zoom, and we'll go from there. It doesn't mean that we don't want to hear all that you have to say, but you certainly are welcome to submit longer written testimony for the record. So I have 4 seats. I'll call the first 4. Justin Palmer, District Hospital Association. Rachel White from DC Action. Joy Okalabadi. Okay, sorry if I tried. Lynette Gonzalez. Okay, Justin, when you're ready.
All right. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Justin Palmer, and I am the Vice President for Public Policy and External Affairs at the District of Columbia Hospital Association. I appreciate the opportunity to present testimony at the Department of Behavioral Health's FY26 Performance Oversight hearing. As you're aware, DCHA is the unifying voice of the district's hospitals and represents the interests of our members who provide care to residents in all 8 wards, our neighbors in Maryland and Virginia, and patients from around the world. Ensuring the district residents have access to full continuum of behavioral health services is critical to helping individuals, families stabilize, recover, and thrive. DCHA and our member hospitals have valued our partnership with the Department of Behavioral Health and appreciates the department's continued collaboration with hospitals to strengthen the behavioral health system. DCHA has proudly partnered with DBH on several initiatives aimed at improving early identification and intervention of alcohol and drug use, reducing the severity of substance use, and enhancing patient outcomes. One of our longest standing collaborations is the implementation of the Screening, Brief Intervention, and Referral to Treatment, or SBIRT model, to address opioid use. Since the inception of SBIRT and the hospital-based peer support service initiatives, over 1.4 million screenings have occurred, with 66,442 brief interventions and over 18,000 referrals to treatment. Our hospitals have reported 7,400 linkages to treatment. The Hospital Peer Recovery Support Services program continues to grow. In August of 2025, the program expanded to Children's National Hospital, providing SBIRT screenings for patients 12 to 21, as well as distributing naloxone to at-risk youth. We are also pleased to share that Cedar Hill Regional Medical Center, GW Health, recently began onboarding for the program. With the work of our hospitals and the District Stabilization Center, fatal opioid overdoses have continued to decline in the district in 2025. While these efforts represent important progress, our members remain concerned about behavioral health system capacity, particularly as it relates to the need for community-based services and outpatient services. As I have testified before, we are concerned that a growing number of admissions at St. Elizabeth's are being reserved for forensic admissions, which limits the hospital's ability to take civil commitments. This is not a shortcoming of the hospital, but rather shows the community demand exceeds the current capacity. For our most recent monthly utilization report showing that there are nearly 200 civil psychiatric admissions in the district, St. Elizabeth accounts for 1 or 2 civil commitments per month. Our members are continue to support access to DBH's emergency psychiatric pharmacy services. The community relies on the pharmacy to provide timely access to critical psychiatric medications for patients in crisis. Without it, hospitals could see higher acuity patients. In addition, we continue to see a growing number of partial hospitalization and intensive outpatient programs for children and adolescents, as well as wraparound services that coordinate mental health, education, support services. DCHA and its members remain committed to working with DBH to strengthen behavioral health and better serve patients in the district. Thank you. Happy to answer any questions.
Thank you. Rachel?
Good morning, Chair Henderson and members of the Health Committee, and happy Black History Month. My name is Rachel White, and I'm the Deputy Director of Youth Advocacy at DC Action. I'm here today to speak specifically around transition age youth, or TAY, young people ages 18 to 24, and their access to mental health care, and what DBH's own oversight responses tell us about where the system is falling short. Across our work, we consistently hear the same thing from young people and providers. Transition age youth struggle to get timely, consistent mental health care that actually fits their lives. Long waits for therapy, difficulty finding providers who specialize in young adults, and disruption in care are common, especially for TAY navigating housing instability, system involvement, or economic insecurity. DBH's responses do reflect effort. There are training initiatives, new frameworks, and partnerships underway, but their responses also make something very clear. Access for transition age youth is being constrained by workforce capacity. DBH reports that it does not currently track how many clinicians in the system have youth or transition age youth specific expertise. Without that basic information, it's difficult to know whether workforce investments are actually improving access for young adults. This becomes even more concerning when we look at TAY specific models. DBH anticipates that only 2 providers will qualify as TAY choice providers in fiscal year 26. 2 providers cannot meet the needs of thousands of young adults across the district, particularly those navigating homelessness, school disengagement, or justice system involvement. As a result, many transition age youth are routed into adult oriented systems by default. And while adult systems may work well for some people, they often do not align with the developmental needs of young adults, which increases the risk that TAY youth will disengage from care, excuse me, altogether. These challenges are more acute for transition age youth experiencing homelessness. Young adults who are couch surfing, living in shelters, or cycling through temporary housing are dealing with trauma alongside instability. Traditional clinic-based models, which rely on regular appointments, transportation, and consistent contact, are often a poor fit for their realities. For these young people, access depends on TAY-trained clinicians being embedded in places that they already go, like drop-in centers, schools, housing programs. When workforce isn't available, engagement breaks down early. Another issue is visibility. DBH relies primarily on claims data to understand service use, but claims data cannot show how long young people waited for therapy, how many referrals fell through, or how many disengaged before care really began. Finally, engagement matters. DBH reports that there are currently 0 certified peer navigators for transition age youth following the loss of prior youth peer roles. For young adults who may trust the system or feel disconnected, peers are often the bridge into sustained engagement. The main takeaways for the council, I would like you to focus on tracking and growing the TAY specialized workforce, expanding TAY specific provider capacity beyond pilot scale, restoring peer and lived experience roles, and investing in service models that meet young people where they are. Thank you.
Thank you. Joy?
Good morning, Chairperson Anderson and members of the community and health. My name is Joy Okagbodi, and I am an early childhood educator and program director at Away from Home Child Development Center. I oversee 2 early learning programs located in Ward 5 and Ward 8. serving infants, toddlers, young children, and their families across our community. I'm submitting this testimony in strong support of the Edu Future program. As a program leader, I work closely with children, families, and educators every day. I see firsthand the growing social, emotional, and behavioral needs of every young children, especially infant and toddlers who are still learning how to communicate their needs. Healthy Future has been a critical support to our program. Through infant and toddler mental health consultation, clinicians work directly alongside our educators by observing classrooms, coaching teachers, and helping staff understand children's behavior as communication rather than defiance. Before LD Future, educators often felt overwhelmed responding to challenging behaviors. With LD Future, with LD Future, they support our teach with LD Future support, teachers gain practical strategies, confidence, and emotional support. As a result, classroom climate improved, educators' stress decreased, and children became more regulated and engaged in learning. LD Future also strengthens relationship with families. Parents feel supported instead of blamed, and concerns are addressed early before they escalate into crises that can lead to suspension, expulsion, or disruption in care. This program is especially critical for young children under 3 when brain development is at its most rapid. Early identification and early intervention during this period lead to better outcomes for children and long-term savings for the district. I also want to emphasize that demand for LD Future exceeds supply. Many early learning programs want access to this support but are still waiting, even as the program has already experienced funding reduction. If LD Future is cut, programs like mine will be left with an impossible choice, choosing between meeting children's mental health needs and keeping classroom staff. I respectfully urge the council to protect LD Future from further cuts and maintain current funding and staffing levels within the program armless in the fiscal year 27 budget. Thank you.
Thank you. Lynette?
Good morning, Chairwoman Henderson, and members of the Committee on Health. My name is Lynette Gonzalez, and I am the Director of Education at Bright Beginnings in Ward 8, an early learning program serving infants, toddlers, and preschoolers here in the district. I've worked in early childhood education for 25 years, and I'm here today to testify in strong support of the Healthy Futures program. Healthy Futures has become an essential part of how we support our children, our educators, and our families. At our Bright Beginning sites, we are fortunate to work with 3 Healthy Futures clinicians, Penny, Siobhan, and Dr. Elia, who provide early childhood mental health supports directly in classrooms, coach educators in real time, and build deep relationships with families. They're not an add-on. They're a missing piece that makes our entire program stronger. Healthy Futures also plays a critical role in supporting educators and preventing burnout. When I arrived at Bright Beginnings, we were navigating significant behavioral challenges and an increasing number of children with autism spectrum disorder. Our Healthy Futures clinicians didn't just create behavior plans. They modeled strategies in the classrooms, coached teachers hands-on, and created a safe space for educators to say, "I need help." Healthy Futures allows us to meet children where they are. Instead of punishing behaviors we don't just yet understand, that kind of support keeps teachers in classrooms and helps them feel confident rather than overwhelmed. Right now, Healthy Futures is helping to stabilize our classroom, strengthening family relationships and preventing challenges from escalating into crisis. I also want to share, and I really want to share this, that Bright Beginnings has 2 additional locations, one in Southeast and one in Northeast, that would greatly benefit from the same level of support. While today is not an expansion ask, I see every day how powerful this program is, how much more we could do if more funding were allowed and capacity of Healthy Futures. I urge the council to protect Healthy Futures from future cuts and maintain current funding levels. This program is working. Losing it would directly harm children, families, and early childhood workforce at a time when stability matters more than ever. Thank you for the opportunity to testify and for your continued support of early childhood mental health in the district.
Great. Thank you so much to this panel of witnesses. Joy and Lynette, you did great. The other 2 are great too, but they've been here before, so it's fine. I'll start with that. I think the Healthy Futures program is one of those programs at DBH that a lot of people don't know about, but it does have a very big impact. And especially when we think about the continuum of early childhood education, for whatever reason, some people have convinced themselves that services and support is not necessary until a child is like in full school, in pre-K 3, pre-K 4, when in fact early intervention could help so much more in terms of the transition even to school, but also for families as well. And while pediatricians are great, they have limitations on what they can do. And so Healthy Futures is one of those things that I feel like has been providing some additional support. So I appreciate you all being here and providing some testimony about the real impact that that program has had. Rachel, I wanted to ask you about the workforce in terms of transition age youth, which you pointed to as being sort of critical here. I think you said in your testimony, I think there are like 2 providers maybe. Um, what's the barrier here? And is there some other jurisdiction that's sort of doing this better? I don't like to always compare because everybody's like, oh my gosh, DC is so unique. But we're not a special snowflake in a lot of different regards. And if there's something that others are doing better that we're not doing, what is that?
So as far as other jurisdictions, there's a mental health shortage everywhere. And so it's not, unique to DC specifically. But what I will say, it's the incentives to stay. Youth homelessness providers, when we talk to them, youth mental health providers, when we talk to them, it's because they're passionate about working there. But a lot of them will tell you that they're not being paid enough or they're not incentivized to stay. And so they can make more money in private practice. So it really is like being able to offer competitive wages. And also like even schools. So Catholic University here in DC, they do provide a specialized track for the youth behavioral health workforce, specifically for youth homelessness, but that's just only one program. Like if we could expand those programs to other schools, or so that that pilot isn't just funded by philanthropic dollars, then more people could enter that track and be basically paid. They get a $25,000 stipend to work in youth homelessness services.
Okay. All right. Thank you.
You're welcome.
Mr. Palmer, so we have, I guess, been in sort of this ongoing conversations with hospitals around capacity. And a lot of your testimony talked about, right, what is the capacity in terms of civil? Um, have your members ever done sort of a census of how many patients are either in your ED or are frequent flyers in the ED who probably would be better served in a different setting other than an emergency room?
I don't think we've done an exact analysis. They probably do know who their frequent visitors are in that standpoint. We can do some collection of what that would be. But certainly all resources, individuals have to be willing to accept them.
Yeah.
And from that standpoint, but it's something that we can dig into. We're about to do a behavioral health resource assessment in the district,
Okay.
just generally. And so I can make sure that as we're talking, that's part of what we're identifying, what resources are missing. Usually it's, particularly as we're trying to discharge that residential treatment and some of those other aspects, particularly for the youth.
Yeah.
That become challenging.
Because we've been talking about this and we talk about it, and I don't know what is the disconnect or our inability to be able to say, no, if this is like one of those situations, like if you do build it, they will come. Like it won't be an empty bed type of situation, which I feel like is sort of the fear that we have in the district sometimes of that, like, oh, we build it and no one will come. But this is a situation where no, residential treatment is needed
And save
across the
money-
age spectrum
And saves money in the long run.
and saves money in the long run. Okay. Well, love to hear more about the work that you guys are
Great.
going to do on that. But I don't have any further questions for this panel, and I'm trying to be good on my own time. So thank you so much. And please provide your written testimony for the record if you haven't already. Okay. Nicole Travers. All right. Jacqueline Berner, Chris Gamble, and Nicole Bellinis. Is Nicole here? Oh, okay. Okay. Nicole T, when you're ready. All right.
Good morning, Chairperson Henderson and members of the committee. My name is Nicole Travers, and I serve as the Senior Director of Strategic Partnerships at the DC Charter School Alliance, the local nonprofit that advocates on behalf of public charter schools to ensure every student can choose a high-quality public school that prepares them for lifelong success. Before this role, I served as a Ward 7 high school principal, working directly with students, families, and school-based mental health teams. I want to thank DBH and Dr. Bazram for recognizing that our current school-based mental health model is not fully addressing students' needs for exploring and for them exploring alternative solutions. We appreciate the invitation to youth and family advocacy representatives to participate in the coordinating council. That inclusion and collaboration matter. I want to thank Branch Chief Erica Barnes and Dr. Sharnita Scott for conducting additional environmental scan outreach with charter LEAs that were not included in the May 2025 data collection. Having high-quality data to inform decisions on the next steps for a school-based mental health program is crucial. According to NCES, only 48% of public schools report being able to effectively provide mental health services to all students who need them, nearly a 10-point decline since the 21-22 school year. The most commonly cited barriers include insufficient staffing, inadequate funding, and limited access to licensed professionals. Here in DC, the challenge is just as urgent. Data from the DC Policy Center showed that 40% of students were chronically absent during the 23-24 school year, a trend frequently linked to unmet emotional, social, or clinical needs. In wards 5 through 8, between 25 to 38% of charter schools lack an on-site DBH or CBO mental health professional, limiting students' ability to access care during the day. Further heightening this concern, of the 9 charter campuses without a nurse or a health tech, 7 also lack a mental health provider, leaving schools to fund critical resources and wraparound support. While we recognize DBH's intent to address vacancies and expand coverage, we are concerned that the proposed in-house model, coupled with an aggressive implementation timeline, risks gaps in care and unintended harm. Therefore, we remain deeply concerned about 3 core issues, and we offer the following recommendations. First, the proposed DBH model and the rapid implementation can disrupt the continuity of care. Abrupt provider changes and the loss of established clinical relationships can negatively affect students' social emotional development, attendance, and academic outcomes. We strongly encourage a phased rollout of the proposal, accompanied by a published timeline and a clear evaluation framework for both DBH and community-based providers. This approach would enable course corrections and alignment with lessons learned from DC Health's school-based medical model transition, which is currently underway. Second, we recommend that schools be allowed to review the environmental scan data and advocate for model types based on their needs at least 6 months to a year before the model assignments are finalized, using a transparent rubric with clear objective criteria. Third, the model does not expand in-person clinical capacity. Instead, it spreads current capacity across more schools and transitions high schools and adult schools to a telehealth model. Therefore, we recommend that the telehealth component be at least hybrid for high schools so that students can build genuine relationships before transitioning. Thank you, and I appreciate your questions. I know I'm at time.
Thank you. Jacqueline?
Good morning, Chairperson Henderson and committee members. Thank you for this opportunity to testify. My name is Jacqueline Verner, and I am an attorney at Disability Rights DC at University Legal Services, the designated protection and advocacy program for people with disabilities in DC. Pursuant to our federal mandate, DRDC advocates on behalf of hundreds of DC residents with mental illness each year. My testimony today is focused on 3 areas that I will just touch on briefly right now. First, we continue to be deeply concerned about DBH's waning commitment toward housing individuals with serious and persistent mental illness. There continues to be a trend of rapidly closing community residential facilities in the district. For context, using DBH's own data from 2018 to 2025, there was roughly a 21% decline in bed capacity. Over the past year, it has just become too difficult to track these numbers, but what is clear is that the system is fragile, and DRDC remains concerned that the overall CRF system is declining. In addition to CRF closures, we also remain concerned about the lack of physically accessible CRFs in the district. In addition, as we highlighted during this committee's recent public hearing on DBH's housing voucher system, DBH asserts that because Dixon has ended, DBH no longer sees providing community-based housing for its consumers as a core responsibility of their agency. In our written testimony, we have provided data that the district used in its 2009 Dixon court filings, where the district highlighted all of the community-based housing for DBH consumers that it created in order to exit the Dixon consent order. We have compared that to DBH's current data, and this comparison shows that DBH now provides over 400 less housing placements for its consumers compared to that time. We acknowledge that since 2009, the district has made significant investments in other housing options, such as permanent supportive housing, and that there are DBH consumers who are housed in those resources instead of DBH's own resources. However, individuals residing at St. Elizabeth's Hospital, in nursing facilities, and in CRFs are not generally eligible for PSH vouchers. And so that decline in DBH's own housing continuum is related to the unnecessary institutionalization of mental health consumers in these settings. Second, we are concerned about the district's decision to contract with CoImagine Health as a prior authorizer for behavioral health services. DRDC and other legal advocates have experience with CoImagine taking over prior authorizations in the context of private duty nursing services. And in our experience, CoImagine's involvement in those authorizations resulted in widespread across the board reductions to many individuals' PDN services in a way that lacked transparency in violation of their due process rights. We urge DBH and the council to ensure that as CoImagine takes over authorization of behavioral health services, DBH is providing careful oversight in terms of the criteria that CoImagine is using in making its decision, as well as CoImagine's transparency in providing beneficiaries with the information that was used in its decision-making. CoImagine's involvement will result in substantial denials, terminations, and reduction of services, and DBH must be prepared to handle this as it arises. And I know that I am out of time. I will just say my written testimony also discusses that we, of course, have continued concerns about DBH's children and youth services. We appreciate the efforts that the council made to make data available using the DBH service utilization dashboard, but those numbers that are reported on there lack clarity and appear strikingly low. And so again, in our written testimony, we detail that in much more capacity. Thank you again for this opportunity to testify.
Thank you. Chris?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Chris Gamble, and I'm a Behavioral Health Policy Analyst at Children's Law Center. Our clients include children who are in foster care and students with special education needs or health conditions. Across our client communities, we spend significant time trying to identify and coordinate much-needed behavioral health services. However, our clients continue to struggle to get necessary care. We see firsthand the results of persistent gaps in the continuum of care and cuts to vital services. DBH is simply not meeting their goal of providing access to timely, appropriate services. With so many needed improvements to DC's behavioral health system and identified clear opportunities on how to move these forward, DBH has instead kept the system stagnant and even moved it backwards in several ways. DBH must recognize the urgency of a deteriorating system that denies children the services they need. In order to establish trust in their ability to adequately meet the needs of those seeking services, DBH needs to be transparent in their planning processes and include community input. DC residents seeking services know intimately what is and is not working in our system. DBH also must act as a partner with community-based organizations, offering support rather than prioritizing control over service provision. DBH's troubling practice of moving services in-house, first with school-based behavioral health, and potentially next with youth mobile crisis services, creates a rift with CBOs and overpromises results. DBH cannot create an entirely internal behavioral health system, so collaboration with CBOs is essential. We maintain our disagreement with DBH's assertion that CHAMPS offers a duplicative service in the school setting. School-based clinicians rely on CHAMPS to provide additional support when a student is not responsive to their de-escalation strategies or when the multiple tasks they handle on a daily basis are disrupted by a student in crisis. Moreover, DBH is proposing to halt the forward momentum that has been made in the school-based behavioral health program this school year. Thanks to the investments by this committee, DBH is reporting the highest numbers of schools served and the lowest number of clinician vacancies across both DBH and CBOs. DBH's proposed plan takes progress and turns it completely on its head. In many ways, it may feel that the comprehensive plan is presenting us with two choices, but there is a spectrum of choices that we have identified that would minimize disruption. We ask this committee to engage with us and other stakeholders to continue to take steps in the right direction, move away from the status quo, and minimize disruption in school-based services in the district. Again, DBH will need to work alongside CBOs to address the gaps that have languished for years in the continuum of care. Fewer children are able to access CBI services year after year, intermediate levels of care continue lacking, and children experiencing crises still have no place to go that offers extended observation and stabilization. Establishing a cohesive, accessible continuum requires focusing on the long-term benefits to the well-being of children. It requires a vision for what that system will look like, but DBH has struggled to do this in a formal way, leaving its strategic plan known as the Children's Plan without an update for over a decade. We urge the committee to seek answers from DBH on how they will address the gaps in the continuum. Thank you for the opportunity to testify, and I welcome any questions.
Thank you. And Nicole.
Hi, good morning, Chairperson Henderson, members of the Committee on Health. I'm Nicole Belenis, DC Long-Term Care Ombudsman Specialist with Legal Counsel for the Elderly. Thank you so much for the opportunity to provide this testimony on behalf of the approximately 541 district residents receiving long-term care services and supports in mental health community residence facilities. As our office has testified previously, we continue to be concerned about the widespread closures of CRFs. In 2025, we saw an increase in the number of CRF operators deciding to close multiple facilities. Last year, a total of 65 CRF beds were lost at closing facilities, displacing 61 residents. Although a handful of operators opened facilities last year, in 2025, the district lost 20 CRF beds. And just 1 month into 2026, our office has been notified that an additional 8 CRFs will be closing, with one operator announcing the closure of all 6 of their facilities. In addition to an overall loss of beds, the availability of housing for residents in need of a higher level of care, such as supported rehabilitative residents, SRR, or intensive residents, IR, is even more severe. For example, from 2022 to 2026, the number of SRR beds has gone from 201 to 167. Again, 8 facilities have already announced that they're closing this year, so this means another 50 CRF beds will be lost, with potentially more to come. We feel that these numbers signal a disturbing trend that DBH and the Committee on Health should pay close attention to and develop a long-term plan for sustainable housing options for the adult mental health population in DC. The diminishing number of housing options available for adults with mental health challenges, particularly for those needing a higher level of care, has led to an increasing number of residents requiring a move to a nursing home. Our DC nursing homes, however, do not have many vacancies, often leaving the only safe housing options available in out-of-state facilities. Finally, the CRF housing crisis has led to inconsistent options and care coordination for many residents. In one recent instance, a resident has been denied by various assisted living facilities as well as 6 nursing homes in DC. The resident was living in an IR facility. However, following an incident, he was moved to an SRR level of care because there was a vacancy. Due to his various mental health diagnoses, the resident struggles with overstimulation in certain settings. Following another incident at his new SRR placement, the CRF operator began discharge discussions, forcing his team to try to find safe housing according to his level of care needs, which remain at the IR level of care. However, with no current vacancies available, the resident is in limbo in a system where there's seemingly no good options for him to live in the least restrictive environment as he's entitled to. This demonstrates that housing decisions are being made during behavioral crises, with multiple avenues being applied for simultaneously, prioritizing placement to where vacancies are, rather than what is appropriate for the resident's level of care needs. Thank you so much for the opportunity to provide this testimony, and I'm happy to answer any questions.
Okay, thank you so much to this panel of witnesses. Do you have a couple of follow-up questions? Both Nicole and Jacqueline, you both brought up CRFs and sort of this overall need for us to get a handle better on the housing portion. Now, was it I guess it was last year. It's February. So it must have been last year we held our hearing on behavioral health vouchers. Yeah, that was December. Okay. So what is time? We were kind of having this conversation about whether or not DBH should even be in the housing business. Given that they seem to have a very, I don't know, sort of laissez-faire, hands-off approach when it comes to, I'm going to provide you a voucher. Yes, we're going to provide some, the hotline for landlords and that kind of thing. But whether or not this was even part of their core competency, doing the housing portion. And I'm just curious, either of your thoughts on this, because that was something that we were thinking about of like, how do we transition sort of the housing portion over to DHS? but I don't know if DHS is better equipped for this, to be honest. Thoughts?
Yes, thank you for that question. My first thought is that, and to follow up on that last hearing and kind of the responses that they gave, the vouchers that DBH possesses they have different eligibility criteria than the vouchers that DHS
Correct.
is using. And so for people in St. Elizabeth's, in nursing facilities, in CRFs, they're generally not eligible for permanent supportive housing vouchers because they are considered to be housed. And so they don't meet chronic homelessness criteria for those vouchers. And so that's why DBH having their own set aside vouchers for those populations is so important, because there are people in all of those settings that can live independently in their own home, maybe with home and community-based services, if we could get those people to those vouchers, but it's not happening. And so I do think that DBH maintaining its own vouchers is really important. Now, again, integrating it into DHS's system, the issue with that would be all of DHS staff would then have to understand, DBH understands its population better in those settings. And so that would be my one concern. But again, those vouchers are so important for that population.
Okay, Nicole, I don't know if you have any thoughts. Okay, all right. So we are holding a roundtable on CRFs in March. I think this says March 26th. Is that correct? 26th. And this is an issue that I think you guys sort of started to raise the alarm last year about the number of closures that were happening. And so I will just say this as a PSA. If any of these operators who are choosing to close a lot of their facilities, including the one, Nicole, that you talked about, who is closing 6 of their facilities at one time, we'd love to understand why. So please reach out to the committee. Is it cost? Is it reimbursement? Like, what is it that is not working very well? Because, we're losing them faster than we can add them. And so we're a net loss every year. Nicole Travers, I wanted to ask you about the school-based behavioral health. So thank you for bringing up and talking about allowing schools to review the environmental scan data to correct for any inaccuracies, and we'll certainly bring that up. We requested the environmental scan data last year. We just got it yesterday. So, we'll look at it before we get to Wednesday. Wow. What a wow. And trying to better understand that, because I feel like if the environmental scan data is the basis for decision making and the data is incorrect, then some schools, like you talked about, who may not have anybody in their building, would certainly be left behind. Do you want to?
Thank you for bringing that up, and just for allowing me to emphasize on the concern that school leaders have. They are really in a place where they want to see what information and data was collected from them, from those environmental scan interviews. Those were conversations that occurred. And so and that happened in the spring of last year. As you know, populations change, the demographic may change, and environmental situations create a higher need depending on the time that we're in the school year. And so school leaders want the opportunity to be able to name, hey, well, this may have been what we needed at that time, but this is what our population currently looks like now. So being able to react and respond to the data will help them to be able to advocate for the type of model that's being proposed for them.
Yeah. And I mean, to Chris's point, right, this is something similar to what we already do on DC Health. They're looking at an environmental scan before they make the appointments around school nurses. And then they give schools the opportunity to appeal, because now if you have a student who showed up during the first week of school, who now, has some other sort of medication requirement, then there needs to be the ability to sort of make adjustments. I would say I'm deeply skeptical of DBH's ability to pull this off for next school year, but we'll see. Anywho, thank you so much for all of you for being here. I don't have any further questions. If you could make sure you have your written testimony for the record. Thank you. Okay. Jessica Rice Longnecker. Relinda Rhodes. Asia Felder Watkins. Got Robert Vincent Branham. I saw him. Okay. Kristen Ewing. There she is. Okay, Jessica, when you're ready. Oh, you gotta just hit the button in front of you and turn your mic on. There you go.
Good morning.
Morning.
Thank you for the opportunity to testify, Chairwoman Henderson and anyone who's listening. My name is Jessica Rice, and I serve as the Director of Behavioral Health Services at the Latin American Youth Center, and I'm testifying today about the school-based mental health and my concerns about their plan for this program. LEYC has proudly served as a school-based mental health provider in the district since the program's inception, and our longstanding experience gives us a clear perspective on what the young people need most from the system and what must be protected as the district considers changes to the program. Across the years of work in schools, several themes consistently emerge: the need for access and the importance of prevention and the central role of trust. So LEYC agrees that the district must improve coordination and better use of the available data to ensure that all schools have mental health services. And as an active member of the DC Behavioral Health Association, we strongly support their recommendations to expand access in ways that are thoughtful and data-driven and non-disruptive. Despite workforce shortages citywide, LEYC was fully staffed last year and is again fully staffed this school year with 8 clinicians in 8 schools. Currently, 116 students across these schools are enrolled with us for mental health treatment, but several of our schools have waitlists exceeding 20 students. And we also utilize clinical interns and referrals to our office and community-based mental health services, though those caseload contributions would not be reflected in the numbers. LEYC's positive youth development model underscores a truth that cannot be ignored. Effective prevention is built on trust and relationships and responsiveness to community needs. Prevention is more than curriculum delivery. Students, families, and educators are coping with economic hardship, community violence, chronic stress, and real prevention requires meeting families where they are, sometimes literally. At one of our schools, for example, families consistently tell us that they don't need another parenting workshop, but they will show up for food pantry events. These events allow us to build relationships while providing resources on coping skills, family communication, community supports. At another school, students disengage from lecture-style programming, but fully participate in co-led groups with clinicians and peers on topics like truancy, substance use, or community violence. These approaches reduce stigma, open doors for earlier intervention, and create the trust necessary for young people to seek help. I am concerned both about DBH's definition of the work prevention and how they limit what data they present. More than 80% of LEYC's school-based mental health students last year received both therapy and clinical case management, which demonstrates both the complexity of the needs, but also the added value of community agencies. And in addition to school-based therapy, students have access to LEYC's after-school programs, summer programs, medication management, holistic wraparound supports. The demand for crisis response continues to rise as well. As of now, in this school year, LEYC clinicians in our 8 schools have been engaged in over 70 school-based crisis responses and have conducted over 200 hours of immediate student support in terms of outreach and walk-in encounters. These numbers represent real moments where trusted school-based clinicians made the difference. So now is not the time for disruption. The mental health landscape for youth is alarming. Hospitals are reporting 3 times as many young people presenting with suicidal ideation, which demonstrates not only heightened need, but also the importance of stability, trust, and continuity in the systems that support young people. Disrupting established school-based partnerships at this time risks eroding trust that providers have spent years building with families, students, and school staff.
Thank you.
Trust is not interchangeable.
Thank you. Ms. Rhodes. Oh, you got to turn your mic on. There you go.
Good morning. Good morning to Chairperson Henderson and the Committee on Health. I'm Rolinda Rose, a certified peer with the Department of Behavioral Health, and I work at the DC Stabilization Center. I've been employed there since March of 2024. And as a peer recovery coach at Community Bridges and a resident of the District of Columbia, I wish to express my strong support for the District of Columbia Stabilization Center, while also highlighting critical operational challenges that threaten its effectiveness and the safety of both staff and patients. It is crucial that these issues be addressed during your committee oversight efforts. The DC Stabilization Center is a vital resource to our community. Having welcomed over 5,300 admissions, this demonstrates that the center importance is addressing the community needs. Despite these achievements, the Stabilization Center faces numerous significant challenges that hinders its ability to serve our community. Staffing shortages with Community Bridges has compelled them to fly staff from Arizona to fill workforce gaps, exacerbating the disconnect between local operations and the Arizona headquarters. This reliance, we are critically missing key personnel, including a certified addiction counselor who resigned January 2025 and has yet to be filled, social worker who resigned shortly after that, and that position was filled for less than 30 days and they resigned. We're also missing vital staff like patient care technicians, peer recovery coaches, which further complicate our mission. The intake process often takes up to 4 hours to often takes up to 4 hours due to staffing shortage and unreliable internet connectivity. Patients have learned that first responders and emergency services receive priority, prompting many to call 911 for transport to the center, knowing they will be seen first. This practice contradicts the DC Stabilization Center's goal for reducing emergency services overuse and complicates our operations further. Moreover, the prolonged intake process poses risk to vulnerable patients who may become target for aggressive patients sitting in the waiting room. We need to ensure timely and efficient intake is essential for safeguarding the well-being of all individuals, including patients and staff. A lack of continuity in operational procedures and poor time management have led staff to prioritize non-essential activities over critical patient care. This fosters an environment where patients are treated as objects rather than individuals deserving dignity and respect. Safety risks. We have patients that are brandishing weapons and have controlled substances coming in and out of the center due to, we did have security from the district government and they were removed from the premises and now staff is required to be the security. The absence of clear operation procedures have created a culture of uncertainty, frequent changes in processes, coupled with lack of accountability, results in confusion among staff. Although we often start strong, many revert to outdated practices. We need oversight. We need accountability. We're looking to you to help us to be what we created the Stabilization Center to be. It is not a daycare center. It is not a drop-off center. We need to have vital staff to be able to connect them to case management, to get them into treatment, and more than that, to give them the dignity and the respect that they're looking for and to receive the services that they're getting instead of transporting them from the emergency room, from one core service agency to another and dropping them off at the stabilization center and they're not getting the services that they need to be productive.
Okay.
I've been in recovery for 23 years, managing my bipolar depression and PTSD. And I've been in recovery from PCP for 23 years. Haven't been in anybody's jail. And that's because I did boots on the ground. Let's get it together, DBH.
Okay. Thank you. Asia?
Good morning, City Council. Thank you for considering my remarks today. My name is Asia Felder-Watkins, and I am writing to express my strong support for Latin American Youth Center and the vital services for students, families, and school communities. I serve as a school-based mental health clinician for 5 years at Eastern Senior High School, working with youth through LAYC. I see every day how our mission positively affects young people, particularly those facing significant social, emotional, environmental difficulties. LAYC aims to empower all youth to transition successfully into adulthood by offering innovative and comprehensive programs that address social, academic, and career needs. We are committed to helping every young person pursue their ambitions, achieve their goals, and develop the confidence and skills needed for a life filled with purpose, connection, contribution, and happiness. This mission guides every aspect of the support I offer in my school. A key factor in youth success is consistent relationships with caring adults. In my role, I witnessed the profound difference such relationships make. My work is not only about aiding students in crisis or during challenging periods, but also about helping them adopt healthier behaviors, gain deeper insight to self-understanding, and achieve lasting emotional well-being. Working at LAYC enables me to do this intentionally and effectively because the organization's values align closely with mine both personally and professionally. LAYC offers safe and inclusive spaces where you feel acknowledged and supported. Through our academic programs, arts and recreation, job readiness training, secure housing initiatives, and healthcare services, we provide stability and help youth move towards productive and fulfilling lives. These supports are essential in our schools. Where genuine engagement is critical for student growth, trust, and stability. Despite these efforts, our school community faces significant challenges. This year alone, I have handled over 30 referrals in addition to ongoing crisis interventions, re-entry meetings, consultations with staff, participation on the wellness team, parent outreach, and managing my regular caseload. These tasks are crucial and reflect both the urgency and increase in our students' mental health needs. I have also observed the growing needs among homelessness and students and families and students under guardianship who rely on resources like our food pantry and case management to support stabilization. Our ability to offer culturally and linguistically appropriate services, particularly for Spanish-speaking students and families, ensures equitable access to care for our students. LAYC psychiatric support also allows me to refer students for assessments in-house and for medication management as needed. Many students would not receive this continuum of care without LAYC. The supportive environment at LAYC is equally important for staff well-being. The emotional demands of this work are high, but the center's positive and wellness-oriented culture enables me to support students wholeheartedly and sustainably. LAYC's commitment to therapist well-being ensures I can navigate my day best each day. Going forward, I hope to continue supporting students holistically, building strong relationships, and contributing to meaningful change within our school community. Achieving this relies on ongoing presence, partnership, and support for LAYC in the services we deliver. For all these reasons, I strongly advocate for ongoing and increased support of LAYC. The needs are serious, the obstacles substantial, and the outcomes for our work are truly transformative. Continued investment in LAYC means investing in long-term success, safety, and mental health for our youth.
Thank
You
you.
for your time.
Okay, guys. Everybody keep going over, and I'm giving you grace, but we're gonna have to use the buzzer in a minute here, and you looking at the clock and you keep talking, okay? It's all good. Kristen,
So much pressure.
I know. Let's see. All right, go ahead.
Good morning. My name is Kristen Ewing, and I am Policy Counsel at DC Appleseed and co-chair of the Strengthening Families Coalition. Today, I want to focus on two issues: school-based behavioral health and crisis response. School-based behavioral health is one of the district's most important investments in student well-being. While expanding access is important, DBH's comprehensive plan, which proposes a rapid transition to a fully in-house staffing model, raises serious feasibility and stability concerns. First, staffing. DBH projects hiring approximately 24 school-based employees in fiscal year 26, yet has reportedly only made offers to 3. At the same time, the department anticipates hiring dozens more clinicians next year, a scale-up that seems unrealistic. The second concern is disruption. This year's increased grants amount enabled CBOs to fill vacancies and stabilize staffing, demonstrating that when adequately resourced, these providers can recruit and retain clinicians. Eliminating a clinician and school relationship just when CBOs have been given enough funding to make their programs viable is unnecessarily disruptive. The third concern is planning and implementation. Key DBH deliverables, including the rate study, environmental scan, and detailed implementation plan, have been delayed, and the comprehensive plan and environmental scan lack sufficient detail and stakeholder engagement. Together, these issues undermine trust and raise serious questions about DBH's readiness to manage a wholesale system redesign. At this moment, the district should prioritize stabilization over acceleration, preserving what is working and ensuring changes are phased, data-driven, and realistic. Turning to crisis response. Behavioral health crises are public health emergencies and should be treated with the urgency and supported by infrastructure. The district has made meaningful progress through investments in CRT, CHAMPS, 988, and stabilization centers, although we still need a youth stabilization center. However, current crisis team response times demonstrate insufficient capacity. CHAMP's average fiscal 20-year response time was 35 minutes and has increased to 58 minutes this year. The average CRT response time in fiscal year 25 was 91 minutes. If fire, EMS, or police had response times approaching an hour, the district would be rightly outraged. Further, DBH has considered bringing CHAMPS in-house and folding these responsibilities into CRT, significantly expanding CRT's responsibilities and scope before current performance challenges have been resolved. Dissolving CHAMPS and removing clinicians specifically trained and dedicated to youth is alarming at a moment when we see increased youth mental health challenges. Further, when mobile crisis response is delayed or unavailable for adults and youth alike, police often become the default first responders, an outcome that undermines the district goals for a non-police trauma-informed crisis system. To improve equity and response times, crisis teams should be deployed closer to where people live through decentralized ward-based hubs co-located with trusted community providers such as FEMS facilities, mirroring practices used by fire and EMS. Over the longer term, the district should consider formalizing civilian behavioral health response as a core public safety function alongside police and fire, as other jurisdictions have done in community safety departments. Thank you for your oversight and commitment to behavioral health in the district. I have submitted more detailed written testimony and I welcome any questions.
Thank you. All right. Thank you so much to this panel of witnesses. There are a variety of different things here. I wanted to ask, hang on one second. Okay, I'm going to start with Ms. Rhodes. Ms. Rhodes, thank you for your testimony. And also, I'm so deeply disappointed because I had under the illusion that the DC Stabilization Center was actually one of the things that was working for DBH, particularly in the last year. When the Stabilization Center opened, it was too much fanfare. We applauded the number of individuals that they had seen. FEMS had nothing but praise in terms of their ability to help get people in. The hospitals also had nothing but praise because they saw, the emergency beds were no longer being taken up by individuals who just needed time to detox, but then also time to build a relationship with peer specialists like yourself and others to get connected to care. And so to hear about these staffing shortages and others and no security is deeply, deeply troubling. When did the security part, let's start there. When did security stop? Because even when I visited, I've been to the Stabilization Center maybe 3 or 4 times at this point, and every time there was somebody there that you had to, see at the front desk before you went in.
Yeah, so they removed the district government security, I believe, in late 2024, maybe early 2025.
Okay.
And then they created a position called the lobby peer, where they train them to the best of their ability, but we don't have any security background. We do the best that we can do to pat people down, but we've gotten patients with knives in the back, cell phones. I mean, just all kinds of objects that shouldn't be back there, and specifically even controlled substances. And so I think that we need to revisit that security piece and what that really looks like, because it puts people in jeopardy, not just the patients, but also the staff members.
Yeah.
And we do have a no wrong door policy, which I totally get as being a woman living with a disability. Of course, we don't want labels and stigmas, but we also need to be able to be safe and secure in that space.
Yeah.
And what that looks like. And we do have a serious staffing issue. We have not had an addiction counselor since January of 2025. And so, yeah.
Which is kind of key for a stabilization.
It 100% is. So let me say this. Yes, it has been working well for FEMS. Yes, it has been working. That's really good to get the patients exactly where they need to go, out of the emergency room, clearing it up so the emergency room can be clear for serious emergencies. We know that, but it's not a daycare. And once they get there, of course, they've had over 5,300 admissions, but to be realistic, because there's no behavior contracts, they can come in and they can do whatever they want. They can cuss, scream, fight one another. They can leave and they can discharge and come back. We've had patients to intake, discharge, intake, discharge, intake, discharge up to 3 or 4 times in one day in a 24-hour period. And they're counting that in the data. I mean, there has been a lot of successes, but we're not talking about the successes. We're talking about the barriers. And right now we're severely understaffed. There's a lack of accountability. There's a lack of continuity. Every other week we're doing some kind of new processes, a new procedures that they think or they want to happen. One, because we have to be certified for this, for that, for DBH. But at the end of the day, it starts off strong. And then 2 weeks later, they're reverting back to what they were doing before.
Yeah.
We've had a lack of leadership in the evening time. I worked the overnight shift, 7 p.m. to 7:30. I got off 7:30 this morning and waited around. That's why I fumbled a little bit because I'm exhausted.
Oh my
But I
gosh.
needed to come here because I'm the evidence of what recovery looks like. And we have a lot of hopeful people. We've had people that have been there every day for almost 2 years and they still lack ID, birth certificates, and social security cards. How are we even gonna get them connected to case management and we're not communicating with the core service agencies or who they're connected with? Or they come in and they have 2 or 3 case managers because they've been shuffled around to this core service agency and then picked up by this one. If you give me $20, then you can come over and change your services over there. And they just keep getting, passed around. And so, yes, it is good that they're not sitting in the emergency room because we have a place that's supposed to connect them to other type of
Yeah, but it's,
services.
as you said,
But we're
it's,
hoarding them.
yeah.
We're only shuffling them around. And then not only that, they have a herding mentality. They get them in and then they get them out. It should be repeating over and over. It shouldn't be taking 4 hours to do an intake. And when you have people in the lobby that are intoxicated, inebriated, they're angry, they're frustrated, and then there's a lack of staff and they come in at 2 o'clock in the afternoon and they don't get a chair until 9, 10 o'clock in the evening. And, and they are feeding off of one another because they're intoxicated and then we don't have enough staff. Like, this creates a very safe environment. And the reality is a lot of these patients are very vulnerable. They are not good advocates of themselves, but if they had a team and they had an advocate, DC government will have a serious problem.
Yeah.
With neglect.
Okay. Well, thank you so much for being here and for, I wish you had said something. I would have put you first so you can go home and take a nap. Because you've been just sort of running on fumes here. But no, I appreciate that. And to be honest, I mean, in these types of situations, right? Because it is not DBH who is running the center, it is a contractor. If I were to ask DBH how things are going, they would tell me it's beautiful.
Well, not
Right.
necessarily, because they were put on corrective action a couple of months ago because I advocated for the patients.
Yeah. So we'll certainly ask questions and follow up on that front, especially as, DC is in the process of building another stabilization center. And we have been advocating actually for a stabilization center to be east of the river. But if we need to reevaluate who our contractor is, then we need to reevaluate who our contractor
Especially the
is.
security issue. And we look forward to having stabilization centers all over the city because when we do it and we do it right, is extremely successful.
When it's
But
done right is the key.
when it's done right is the key. We
Okay.
cannot wash, rinse, and repeat. We deserve more.
Thank you. Thank you for being here. Okay, so I wanted to ask our folks from LAYC. So we had asked DBH about this creation, and I guess this is also Kristen, you can jump in here as well. We had asked DBH in the pre-hearing responses about the creation of the district's comprehensive quote unquote children's plan. So it was last updated in 2012. DBH had indicated to us that, they're going to do a plan update in FY 2025, but it has yet to be published. For those watching at home, it is FY 26. So they're late. In their responses, they said in August of their date is wrong because they say in August of 2026, a group convened, but we know that's not possible. So let's say that was supposed to be 25. They said a group convened and team leads shared some preliminary recommendations to be included in the children's plan. They talked about how they brought together community-based organizations and other stakeholders to participate. Are any of you familiar with the stakeholder conversations that happened for the creation of the children's plan?
No.
Okay. So LAYC, who is like one of our largest providers, didn't know. All right. I'll ask the other youth ones. I was supposed to ask Chris Gamble this question when he was at the table and I missed it. That's okay. You were there? Oh, they were there. Okay. All right. Okay. Well, there's that. We'll ask more on that. We'll follow up with you, Chris. All right. We'll certainly ask some questions about school-based behavioral health in terms of the transition that is planning or underway or how they plan to sort of move in that regard. But Ms. Felder-Watkins, it was great to hear about the work that you guys have been doing in schools. And of course, Ms. Rice Longnecker, just in general, the importance of having cultural competency as part of the care that is being provided. Kristen obviously will also ask about crisis response. The council recently passed, after way too long, our sense of the council around crisis response needing to be an integral part in our public safety response. Because just because someone is in a mental health crisis doesn't mean that they should be met with law enforcement with guns. And I feel like we should be able to do better in terms of our responses there. But thank you all for being here. And please make sure you provide your written testimony for the record if you haven't done so already. Okay, gonna go to our next panel. Aaron Weiss, Gregory Kaufman, oh, Kaufman, all right. Floriela Fuentes. Okay, and Carolyn Greenspan. Great. Okay, Aaron, when you're ready.
Good afternoon, and thank you for the opportunity to testify. My name is Erin Weiss, and I'm a school-based mental health clinician with the Latin American Youth Center. I currently provide direct services to students within Ida B. Wells Middle School, and have done so for the past 3 years. My testimony reflects my daily experience supporting students, families, and school staff, as well as my concerns regarding proposed changes to the Department of Behavioral Health's school-based mental health model. School-based mental health services are most effective when they are stable, relationship-driven, and deeply connected to the communities they serve. Community-based organizations like the Latin American Youth Center play a critical role in making it possible. LOC has served DC families for decades and has built trust across generations. Many caregivers I work with are already familiar with LAYC through past programming, family services, or community outreach, which significantly reduces hesitation and fear around engaging in mental health care. This trust is especially important for immigrant families and families from historically marginalized communities. When services are offered through a familiar community organization, families are more likely to engage consistently, communicate openly, and seek help early rather than during crisis. As a clinician, I see firsthand how LAYC's cultural responsiveness and community presence lower barriers that a centralized or government-only model may unintentionally raise. In addition to therapy, LAYC offers wraparound supports that are essential to student well-being, including case management, housing and immigration-related resources, psychiatry, and youth development programming. These support allow clinicians to address the full context of a student's stressors rather than treating symptoms in isolation. Even in schools served by government providers, community organizations like LAYC are often relied upon to fill gaps that schools and agencies cannot meet alone. I'm also concerned about proposals that would rely heavily on telehealth services or require clinicians to rotate between multiple schools. School-based mental health work is not limited to scheduled therapy sessions. It involves responding to walk-in crises, collaborating with teachers and administrators, attending school meetings, supporting parents, facilitating groups, and helping manage complex transitions throughout the day. These responsibilities require clinicians to be fully embedded in the school community and familiar with each school's culture, routines, and needs. Every school is different. Student populations, family dynamics, staffing structures, and community stressors vary widely across the city. A uniform model risks overlooking those differences and undermining the consistency and trust that students depend on. Frequent clinician changes or remote services can disrupt relationships, delay crisis response, and weaken coordination with school staff. I'm proud of the work we do at LAYC and the partnerships we have built within schools day to day in person, Monday through Friday. Thank you for your time and consideration.
Thank you, Aaron. Gregory? Hold on one second. Aaron and if you guys can turn your mics on because we have too many on at the same time. There we go. All right. Oh, yep. Nope, hit the button. No, hit it. Yeah. Don't be afraid.
All right.
There we go.
Good morning. My name is Greg Kaufman. I am a district government employee as well as the chief shop steward and executive vice president for AFGE Local 383. DBH is one of the agencies that has some of our bargaining unit members, and I'm here to testify on the systemic mismanagement, abuse of authority, and risk to public services present at DBH. The union has identified systemic mismanagement at DBH that is disrupting critical public services, wasting district funds through preventable staff turnover, allowing retaliatory and non-compliant personnel actions, exposing the district to arbitration, EEO, and litigation risks, and undermining workforce stability and grant oversight. First, DBH is failing to meet the most basic requirements of performance management across multiple units, and supervisors, employees report no documented supervision, no clear expectations or feedback. This is not a minor technical failure. Without supervision, performance management becomes arbitrary, unreviewable, and undermining their validity. On 1/12/26, these failures culminated in the termination of 2 probationary employees in the grants management unit that exemplify the performance management failures that the union has observed at DBH. Neither had received documented supervision or corrective guidance. Performance deficiencies cited in their annual performance evaluations had never been relayed to them. One informed the supervisor of potential funding issues by a grantee, potential fraud by a grantee, but DBH paid that grantee despite the notification. The union believes that these terminations were retaliatory. In 2025, DBH told the council it struggled to hire grant management staff. The 2 terminated employees were trainable, and they were also in the grants unit. DBH now will report vacancies in these same positions. The district has lost recruitment, onboarding, and training investments, and grant oversight capacity has been weakened. In a comparable case, the district incurred approximately $95,000 in legal costs, plus the cost of back pay for a premature termination decision. This is preventable waste. Finally, DBH reports to the council that it was developing an automated grants management system. It was reported to the union that as of mid-January, that system is not operational. Grantees reportedly went unpaid while expecting to continue the service. The union respectfully requests that the council review DBH's independent personnel authority, audit performance management and supervision compliance, require centralized HR to review probationary employees' terminations, mandate timely contemporaneous performance documentation and employee discussions, review improper separations, and restore staff where appropriate. Thank you.
Thank you, Greg. Lorella?
Yes, good morning.
Good morning.
My name is Fernanda Cifuentes. I'm a bilingual school-based mental health therapist with LOIC. And I will be reading a statement written by Ms. Nakisha Jones-Helton from Paul Public Charter School, one of our partner schools. To whom it may concern, I'm writing to offer my full support for the continued partnership between Paul Public Charter School and the Latin American Youth Center as a community-based organization. Our partnership with LOIC began in 2020, and over the past 4 years, it has become a critical component of the mental health and wellness support available to our schools, families, and staff. Throughout this partnership, LOIC has consistently provided services to scholars across both our middle school and high school campuses. Monthly caseload data demonstrates sustained engagement with each school serving approximately 10 to 22 scholars per month during each of the past 4 years. This level of participation reflects both the ongoing need within our school community and the trust that scholars and families have developed with LOIC counselors. This partnership has been instrumental in expanding access to mental health and wellness services, particularly for scholars and families who we were previously unable to support due to language barriers. LOIC has provided services in scholars' native languages, allowing for culturally responsive care and stronger family engagement. As a result, scholars are better supported emotionally, socially, and academically. LOIC counselors have become an integral part of the fabric of our school community. They are embedded in our work and serve as members of our internal wellness team, collaborating closely with school leaders, counselors, and culture staff. Their consistent presence and visibility have helped normalize mental health support and ensure that scholars feel safe accessing services when they need it the most. Without LOIC partnership, Paul Public Charter School will face significant gaps in our ability to provide comprehensive mental health and wellness service to a large population of our scholars. Their support allows us to meet the needs of our community in a way that is equitable, accessible, and responsive. We strongly support LOIC continued work as a community-based organization partner and value the impact this collaboration has had on our scholars, families, and staff. We look forward to continuing and strengthening this partnership in the years ahead. Please feel free to contact me if additional information is needed. Sincerely, Nakisha Jones Helton, Assistant Director of Climate, Culture, and Support, Paul Public Charter School.
Thank you. Carolyn?
Hi, my name is Carolyn Greenspan, and I am the Director of School-Based Mental Health at Mary Center. We have 22 school partnerships through the DBH-funded program. Mary Center has been a longtime partner with DBH's School-Based Behavioral Health, or SBBH, program. We appreciate the commitment of staff members like Dr. Scott and Ms. Hammock. I'm testifying today to share what has happened since DBH announced their decision to bring the program in-house. My written testimony shares greater details and examples. Mary Center remains deeply concerned. This plan does not account for the strengths of CBOs, including where we have been effective and successful in serving DC students. A comparison of service reach and billing capacity underscores the strengths of Mary Center as a CBO partner. We were able to provide therapy services for more youth in 2024-2025 in 22 schools than DBH did in 37. In that same time period, we were also able to bill an average of approximately $91,000 per school, as opposed to DBH's average of approximately $6,000 per school. We've also received letters of support from our partner schools I'm happy to share. Despite receiving significant feedback in various ways, DBH recently said in their written answers that they haven't made any significant changes to their plan. This is more than disappointing. It highlights that DBH lacks a clear path for meaningful improvement to school-based behavioral health. The plan fails to address longstanding concerns raised by CBOs, including how DBH measures success. While CBOs are committed to the MTSS model, DBH's implementation has been overly narrow. The school strengthening plan developed with school stakeholders identifies individualized school needs that often do not align with DBH grant requirements. To fulfill DBH's stated intention of using the work plan to meet each school's unique needs, CBOs should be measured by what is in the plan with some broad guidelines from DBH about providing services within each tier. Clinicians' roles in crisis response should also be considered in evaluating CBO performance. Finally, the recently released Child Trends report highlights ongoing challenges in retaining the behavioral health workforce in the district. Mary Center is currently fully staffed, and CBOs across the city report only 2 vacancies. However, the uncertainty created by potential funding losses has caused significant anxiety among our clinicians, and I anticipate increased turnover at the end of the school year. DBH's proposal would require rapidly hiring a large number of clinicians to replace those lost through the elimination of CBO contracts. While DBH may assume clinicians will transition into its open positions, many choose Mary Center because of our shared values and deep community ties. Instead, this proposal risks pushing clinicians out of the SBBH program altogether into private practice or other jurisdictions, creating workforce gaps that could persist for years. And I'll pause there due to time.
Thank you. Thank you to this panel of witnesses. Ms. Greenspan, I will just sort of, draw for something that you talked about at the end around this whole thing sort of creating anxiety amongst the workforce. Unfortunately, I don't have anything satisfying to offer because so much of this is going to be driven by the budget. And while I know in theory what date the budget is supposed to be submitted to the council, I also know that this administration has missed that date for the last 5 years. So it will be the end of the school year before we kind of know what's going to happen, because so much of this is driven by, can they come up with a number of positions and actually hire for that? And I think someone in the previous panel talked about they were supposed to hire this fiscal year like 25 people, and I think they've hired maybe 2 thus far, which we'll certainly follow up and ask questions on that, because November they assured us, oh no, working for DBH is so popular. We'll have no problems getting offers. And so we'll get there. What I wish I could offer something more to the three of you. And Greg is the only one at the panel who's not in the clinician space working in schools. But we're gonna try to get some more details about it on Wednesday. So certainly appreciate you all testifying and also lifting up the work that is happening in the schools. I would say we acknowledge that not all CBOs are made equal. And I'm not saying that to sort of be disparaging, but some CBOs have larger capacity than others. They also have a more historic footing in communities, right? So that has made it easier for them to both recruit and retain staff. And we've had some challenges with some smaller ones. And I think one of the questions that has been floating and was last year was, are there ways that we could build capacity as opposed to sort of throwing, as Jim Graham used to say, don't throw the baby out with the bathwater. So we'll certainly dig more into that. Mr. Kaufman, I was consulting with my staff here because the situation you were describing was different than a different whistleblower complaint that we got a week or so ago, also with regard to what's happening in terms of management at DBH Central, right? So this is separate and apart from everything that was going on at St. Elizabeth's, which we already know is a hot mess, right? So this is just like what's happening in the office there. And I'm like, this is getting harder for us to keep track of what's what, which I think we're going to dig into further. And I appreciate you uplifting the part about the grants management because that has been a consistent push on this committee to get DBH to actually have a grants management system that works better than an Excel document. And they told us a year ago it would be ready because they're getting it from another agency. And the other agency was like, nope. So to hear from you saying, oh, it's not done. Is that what you said? Did you say not done or not even started? Oh, you got to use your mic. Yeah.
It was reported to me that it was supposed to roll out, I believe, in August.
Yeah.
And it hasn't rolled out yet.
Okay. All right. We'll certainly follow up with them on that. And then also I'm suspecting that for the two individuals in the grants management staff that were fired, one of them after raising potential fraud, that you all are going through the grievance process on that?
So they are probationary employees.
Yeah.
So we are going to go through the grievance process, but because they're probationary, that's management's right to terminate people in the probation process, but it's also per the statutes in the DPM and our collective bargaining agreement that the management must provide a fair environment. And because of the systemic issues, the lack of supervision, there is a potential for EEO and retaliatory issues with the terminations. We're going to be filing agreements based on those processes not being followed.
Right. Because in the actual process, at least my understanding, right, even when you're probationary, you are supposed to at least be given the opportunity for corrective action.
Yes. So
in theory,
ideally, what should happen is you should be provided ongoing feedback. And so these members, they stated when they received their evaluation, which was on December 29th, which was like the last day that you could do it.
Yeah.
And the supervisor scheduled that meeting on a Sunday, which was the 28th. They're in their probationary, so they don't know the process. So they go in, they meet, and then after the meeting, they actually review their documents, say, hey, wait a minute, there's so many things that appear wrong. And so the supervisor then goes on leave, but they approach, they CC the supervisor and HR to say, hey, we'd like to discuss this. And after they raised the issue to discuss, the point that they wanted to discuss, they were terminated. One was valuable, a valuable performer. One was marginal. And so the marginal employee really wanted to talk about, hey, I think you got some things wrong here. But that same employee also had a conversation with the supervisor that didn't go well in December. And we believe that the supervisor did not plan on making that person marginal, but because of the conversation in December, the supervisor retaliated against the employee and both subsequently.
Okay. All right. Obviously we can't get into detail specific about employees, but I think just sort of overall, the fact that I'm getting confused on the number of whistleblower complaints that are coming to the committee for one agency in 2 weeks tells me something's wrong. So we'll certainly follow up on those things, but thank you for being here and representing your members. Thank you guys for your testimony today. Okay, we're gonna go to our next panel. Jim Volsky. I got it right? Yeah. Let me tell you, hooked on phonics works. Okay, Yesenia Molina. I'm watching you tell me that the Y is silent. Yesenia? No? Okay. Christina? Kiernitos? No. Lord have mercy. All right. Andrea Martinez. All right. Olga Acosta Price. Her. And Tanya Powell. See Tanya. All right. Laura Mengizer. Mainzinger, excuse me. I'm gonna do better. Okay. While she's coming up, before you guys get started, just to telegraph for the folks in the room, 2 things. One, is there anybody here who you were signed up for virtual, but you came in person? Anybody? Okay. All right. So we're going to do this panel. We're going to do the next panel for in person, and then we're going to take a 5-minute break, and then we're going to do virtual. So I'm just letting folks know. So if you're in that next virtual piece, we are going to take a break after the last panel of in person goes. Okay, Jim.
Good morning, Chairperson Henderson and members and staff of the Committee on Health. I am Jim Volsky, Associate Director of Pediatric Emotional Wellness at Community of Hope, and I've been working in child and adolescent mental health in DC for over 10 years. Excuse me. I am here today to discuss the proposed changes to the school-based mental health comprehensive plan that would disrupt services for students. Community of Hope offers school-based mental health services at 3 sites with funding from the DC Department of Behavioral Health, Moton Elementary in Ward 8, Ketchum Elementary in Ward 8, and Roosevelt High School in Ward 4. All 3 sites are classified as high-need schools, and our clinicians provide one-on-one counseling services to students and their family members, as well as group services to students, teachers, and parents to improve school atmosphere and support student achievement. We also provide students with internal referrals to the wide array of resources offered by Community of Hope, including primary medical care, dental care, psychiatry, and substance use disorder treatment. Students at our 3 SBMH sites are also able to receive specialized medication management services and treatment plans through referrals to Community of Hope by their on-site school clinician. Community of Hope is also a member organization of the DC Behavioral Health Association and has been working with the association to develop alternative recommendations for the creation and implementation of a school-based mental health plan that is both not disruptive for students and budget neutral. We want to highlight some of the concerns that have also been raised by the BHA regarding the new comprehensive plan, particularly around lack of stakeholder input, rushed implementation, and feasibility given the current level of need in schools. Not only was the proposed plan created without vital input from stakeholders, including clinicians, community-based providers, and school communities, the proposed implementation schedule beginning next school year is rushed and likely to disrupt critical services for students rather than improving them. Of the 4 staffing proposals included in DBH's plan, in particular, the full telehealth service model is not practical for the majority of schools, which are providing Tier 3 services to students in high-need school environments. We do believe that a combination of proposed staffing models 1 and 2, which would have 1 on-site clinician to 1 or 2 schools, could be implemented by DBH, continuing to use the community-based providers, and would also be budget neutral. During a time when programs like DC Child and Adolescent Mobile Psychiatric Services, or CHAMPS, are seeing cutbacks and hospitalizations for youth are increasing, it is more important now than ever to prevent disruption to mental health services being provided to kids in schools. The Department of Behavioral Health must work together with providers and other stakeholders to create a plan that is most beneficial to the district students. Thank you for the opportunity to testify today, and I'm available to answer any questions.
Thank you. Andrea? Look, turn on your mic. There you go.
There you go. Okay. Thank you for giving me the opportunity to address the council today. My name is Sandra Lynette Martinez, and I serve as a social emotional support specialist with the Latin American Youth Center, LOIC. My position was initially school-based at Cardoso Education Campus, where I served the school community for a year and a half through the highest needs funding, which was cut last year. Since then, my role transitioned to a community-based model, allowing me to serve youth and families throughout the community to ensure accessibility and continuity of care. I am deeply concerned about the Department of Behavioral Health's plan for reducing the role of community-based agencies and restructuring the federal mental health services as unique providers. Since 1968, LOIC has been uniquely positioned to meet the specific and complex needs of the communities we serve through cultural responsiveness. Through hard and consistent work, we have become a trusted pillar for our community, and now more than ever, we need to support our youth who continue to face the fallout of community violence, housing instability, and immigrant-related trauma. I would like to share one of my first cases at Cardoso Education Campus that highlights the importance of community agencies. During my first week, I was assigned a list of 10 students with identified needs, including a 14-year-old girl who had moved to DC 6 months earlier and had not attended school for 3 months. After connecting with her family, I learned she was afraid to return to school due to ongoing bullying and physical harassment. Her parents faced significant barriers, including language limitations, unfamiliarity with DCPS, housing insecurity, and employment challenges. I provided weekly case management and referred the student to LAYC's school-based clinician. Thanks to holistic care and variety of services we provide, I was able to help the family access essential resources such as medical insurance, food assistance, and referrals to immigrant support services. Working closely with the family, I began working with her brother and connected him to services that help prevent gang involvement. With sustained support throughout the school year, the students successfully graduated middle school with strong academic performance and healthy peer relationships. This case reflects the critical impact of our culturally competent and community-based prevention programs that meet families where they are. I'm currently pursuing my master's in social work and completing my generalist practicum with LOAC, where I have the opportunity to develop clinical skills while serving a community that matters deeply to me. Reducing the role of community-based agencies like LOAC will dismantle trusted systems of care that have taken decades to build and would leave our most vulnerable youth without access to services they can trust and engage with. I urge the Council to protect and invest in community-based providers who have proven record of keeping young people safe, connected, and thriving. Our youth deserve care that is accessible, culturally responsive, and rooted in the communities they call home. Thank you.
Thank you. Olga?
Hello, my name is Olga Acosta-Price. I'm a clinical psychologist and professor at the Milken Institute School of Public Health at GW, where I direct the National Center for Health and Healthcare in Schools. My recognized expertise is in the design, implementation, and evaluation of comprehensive school behavioral health systems. From 1999 to 2006, I served as a founding director of what is the School Behavioral Health Program at DBH. I appreciate this opportunity to address you this morning. There are two main points I'd like to convey in my abbreviated time. First, as was very ably said by others, the timeline to move the entire school behavioral health program to DBH is unnecessarily aggressive and should be slowed down to minimize disruptions to student care and to school relationships that took months and years to cultivate. Secondly, meaningful school, family, and community engagement in the School Behavioral Health Initiative is not a nicety, but an essential element to advancement and ensuring the positive outcomes that we all seek. A November roundtable discussion, which I was able to participate, demonstrated that the overwhelming consensus among community stakeholders was significant apprehension about the validity of the plan. The unreasonable pace and the short-sightedness around the role of CBOs is very likely to dilute the very model that we're trying to preserve and leave schools and families with preventable gaps in support, which risks destabilizing service delivery without improving results. In my 25-year history with DC School Mental Health, I can attest that the best ideas, recommendations, and progress has resulted from families, providers, educators, policymakers, researchers, and advocates working together to ensure health-promoting school communities for all students to thrive. The key to our success was an inclusive process built on meaningful community participation, human-centered design, and collective impact. I applaud some of the principles underlying the plan, such as the importance of public mental health framework, discouraging a one-size-fits-all approach, and recognizing that mental health supports can and should be provided by different types of professionals. But a narrow goal of centralizing delivery of the program misses critical targets for system improvement, including assessing the school's readiness to implement comprehensive school behavioral health, the need to better coordinate technical assistance delivered by multiple partners, and fixing longstanding finance and billing barriers. Structural challenges have been well documented for years, yet meaningful technical assistance and targeted support for CBO success have been largely absent. A transparent examination of why performance metrics weren't when unmet could have uncovered systemic weaknesses and led to constructive data-driven improvements across the system. For example, existing data, including from child trends evaluation, about key concerns such as youth not trusting clinicians or fears around mandated reporting illuminates what may be underlying the utilization of services, an issue that will not be solved by DBH moving the program in-house, but instead requires active listening, collaborative problem-solving, partnership, and innovation. Due to a lack of coordinated system building, we launched the DC Consortium for Mental Health Wellness and Behavioral Health in Schools, DC COMS, with almost 20 organizational partners across DC to elevate community voice, connect research and practice and policy. The DC COMS is poised to assist DBH and CBOs to increase their impact. We're pleased that DBH leadership has reached out to begin a conversation about collaborating, and we welcome open dialogue about how to move from a focus on compliance and oversight to one of system transformation and community ownership. Thank you.
Thank you. Laura.
Good morning, and thank you for the opportunity to testify. My name is Laura Mainzinger, and I'm a school-based mental health therapist with the Latin American Youth Center, serving students at Paul Public Charter School. I'm speaking today from my direct experience providing daily mental health services inside a DC school. I have significant concerns about the proposed direction of DBH's plan, particularly reducing the role of community-based partner agencies, introducing a telehealth model, moving clinicians between schools, and the government being the sole provider of youth mental health services. First, I want to emphasize the immense value that community agencies like LAYC bring into schools. LAYC has been a trusted pillar in the DC community since 1968. When we engage families, our reputation often precedes us. Many parents we serve participated in LAYC programs themselves when they were younger, and they know we offer wraparound services rooted in dignity and cultural responsiveness. This existing trust is essential, especially at a time when many families feel helpless, anxious, and overwhelmed by broader social stressors. For many families, particularly immigrant and Latino families, engaging in services through a trusted community organization feels safer and more accessible than enrolling directly through a government system. As someone who is not a member of the Latin community but works closely with many Latino families, I see how LAYC's cultural competency and deep community roots help build trust and reduce barriers to care. LAYC also provides extensive in-house supports beyond therapy, including case management, housing assistance, psychiatry, youth programming, and social emotional support services. This allows us to ensure continuity of care and connect families to the full range of resources they need. I've previously worked in a school served by a government agency provider, and even then, that provider relied on LAYC for support with housing and migration resources and family engagement they could not fully address alone. I'm also concerned about the proposed telehealth model and rotating clinicians between schools. On paper, our roles might appear to be simply providing back-to-back therapy sessions. In reality, our school-based mental health work is deeply relational and embedded in the school community. Every day, we collaborate with teachers, administrators, culture teams, and families. We facilitate parent meetings, support mediations, provide prevention services in groups, respond to walk-in needs, and manage an increasing number of crises. We also build unique relationships with students and families that allow us to support the broader school community. Teachers regularly consult with us about classroom strategies, and we work closely with school wellness teams to tailor interventions to each school's culture and needs. A one-size-fits-all model does not reflect the reality across DC schools. Having worked in 2 schools in very different parts of the city, I can confidently say that each school community has distinct needs. Telehealth and clinician rotation models risk disrupting continuity of care, weakening relationships, and reducing our ability to respond effectively to crises and evolving student needs. I urge the Council and DBH to continue investing in community partnerships, preserve continuity of care, and ensure that expansion efforts do not come at the cost of quality or trust. Thank you.
Thank you. Thank you to this panel of witnesses. Jim, I wanted to follow up with you really quickly. I think you mentioned that Community of Hope, you have partnerships with 3 schools. Are you guys fully staffed for that at this time?
Yes, we are.
Okay. And what is the conversation amongst your workforce around what has
I
been proposed?
believe the panel earlier conveyed it pretty well when they said staff were anxious. You know, I have my therapists, well, shouldn't say my therapist, the therapists I supervise reaching out to me pretty frequently and being like, well, hey, you know, what can you tell us about whether or not we're going to have a job? And, you know, the answer is at the moment, I can't really tell them anything. And it's not a great environment for them to have to work and function in, especially when they're seeing so many crises, as folks have mentioned, and, you know, high needs situations happening during their day to day. And, you know, I also will brag a little bit that we've been able to retain our staff pretty well. You know, one of our therapists has been with us for 2.5 years. The other just hit 2 years, and the other is coming up on 1 year. So our staff do like to stay with us. We don't have as much turnover as a lot of other places do, but there's definitely a lot of uncertainty, and it's making it harder for the therapists I supervise to do their jobs.
Okay. Dr. Price, I think you have probably the longest background experience sort of dealing with this. Is it of your opinion that so we have some schools that geographically are literally sitting across the street from each other. Like my kid's elementary school is literally across the street from another elementary school. We could have another conversation on another day about like how that is done. But for the purposes of resource sharing, it does present an interesting sort of thought experiment of, is it possible for if one school is not as doesn't have the same sort of high level of caseload, could they sort of share resources? But then there are others who said, no, everybody needs their own person. Now, part of this is difficult in that we don't have the environmental scan data. So I don't know, right, if DCPS school had already had 2 therapists, a psychologist, and 6 social workers. So maybe we could say, okay, yeah, the additional person from DBH can be supplementary, but it's not your main person. Is your thoughts though that couldn't work?
I am not a proponent of such a sort of a blanket approach that every school needs a full-time provider.
Okay.
Having said that, obviously, I'm a very big advocate for comprehensive school behavioral health, and I'm really humbled by these CBOs that have been presenting because they really encapsulate the spirit of what I tried to bring to DC 25 years ago. That I really don't feel DBH can effectively do on their own because of the wraparound that's needed to support our families. But to your question, it really depends, as you very much know, on how we are assessing what it means to have needs within the school. You absolutely can make work sharing resources. If a clinician is working in a strong team that has other folks that where scopes of work are really well understood and
Yep.
divided, where you have other processes in place and the clinician can really come and do some targeted work that's going to supplement what's already there. You can have a half-time person. Again, it isn't about counting how many sessions you do because part of the value, as again, these women have really ably stated, is that you're also trying to improve the climate and the culture of the school, of how they are working. It isn't just about sort of delivering a sort of piecemeal set of interventions because that isn't sustainable. That isn't going to make great impact. It really is about embedding. It's relationally based. It's about the ways that leadership really embrace this new way of trying to operate. It's about true engagement. That takes time, mindset shifts, as well as resource sharing. So yes, geography, being close to each other, not having the same severity of needs can absolutely make a part-time proposal and pilot work. I also am very concerned about this telemental health approach. I think it is about checking boxes and being able to say that there's somebody who might show up, to count a number of students that may be seen. But again, that is not school behavioral health. That is diluting the model and not really what the city and the residents have invested in.
Okay. All right. Well, thank you so much to this panel of witnesses. Thank you for your testimony. Provide your written testimony for the record. Okay, we're going to go to our final in-person panel, and then we're going to take a break as we've been going. All right. Lupe Quinteros Grady, Sabrina Semino, and Maria Acosta. I don't know who's who. Are you Sabrina? Okay. All right. So Maria's not here. Okay. Okay. All right. Ms. Quinteros Grady, when you're ready.
Thank you. Good morning, Chair Henderson. Thank you for the opportunity to testify on the critical needs to strengthen and sustain school-based mental health services across the district. My name is Lupe Grady, and I serve as the presidency of the Latin American Youth Center. Today, I speak on behalf of our clinical team and many community-based providers committed to supporting students and families in the DC public schools. Every day, our school-based clinicians witness students confronting family instability, trauma, poverty, stigma, and systemic barriers that make it difficult for them to thrive in the classroom and beyond. The work is complex, urgent, and deeply relational. I want to reaffirm my agreement with the Department of Behavioral Health's guiding principles, especially the recognition that all students benefit from a school environment that promotes and supports behavioral health, wellness, and resiliency. This statement captures the heart of why we all are here. But living these principles requires real collaboration. It requires that we as a city align our efforts and evidence-based practices with the lived experience of clinicians and families, and this understanding that no single entity can do it alone. What works is not one size fits all. Effective school-based mental health supports looks different from school to school, sometimes even from classroom to classroom. The needs of a small elementary school differ dramatically from those of a large high school. The needs of newcomers differ the needs from LGBTQ youth or youth experiencing homelessness or youth managing family instability and trauma. This is why collaboration, not siloed decision-making, is essential. LAYC teams works tirelessly to build trust with each school community, as you've heard. Trust is not a benchmark. It is a daily practice. It is what allows students to take the vulnerable steps of asking for help. One of our clinicians recently shared the story of a 13-year-old student who had previously attempted suicide multiple times. The student approached the clinician not because the student was referred, but because the therapist was there every day, familiar, visible, and consistent. Students knew her as a safe adult, and because of that presence, this young person was willing to seek help. This relationship quite literally created a path towards healing. This is the essence of school-based mental health. Trusted adults embedded in the school environment whose students seek out on their own. Our clinicians often remind me that no 2 days in a school look the same. They are approached by teachers, administrators, and students constantly, not because of a formal process, but because trust has been built and collaboration feels natural. But creating a school environment that truly supports behavioral health wellness is not easy. Schools carry immense academic, social, operational pressures. They need strong, stable community partnerships. LAYC is proud to stand with our schools, and I am deeply proud of my team for caring not only for the mental health of the students, but for the whole child. Making sure families are connected to food resources, housing supports, and crisis stabilization when needed. As a member of the DC Behavioral Health Association, I also support the recommendations put forward by them. We have had many constructive conversations about DBH's proposed models and different staffing ratios or construct structures that have been provided. We fully support creating more consistent criteria to measure effectiveness across DBH models. We are open, ready, and willingness to continue these discussions and co-design a framework that pairs efficient resource allocation and meaningful trauma-informed student-centered care. Community-based organizations like LAYC are essential pillars in the ecosystem. We have decades of experience, deep relationships with families, bilingual and cultural competent staff, and trust of students who depend on our continued care. The path forward is not one where agencies work in isolation or shift resources away from community providers. It is one where we work together, align with best practices, continue to problem solve collaboratively, and build a resilient, equitable, and sustainable school-based mental health system for all DC students. Thank you so much for your leadership and your commitment to this work.
Thank you. Sabrina.
Hello, testing. Okay.
Happy Monday, happy Black History Month. My name is Sabrina Sermeno, and I'm also here with LAYC. I will be reading a letter of support from one of our partner schools, Eastern High School. Our school's partnership with Latin American Youth Center / Eastern High School partnership has given us valuable opportunities to work closely with students and support every aspect of their development within the educational environment. Thanks to this collaboration, our assigned school clinician, Ms. Asia Felder-Watkins, LPC, has been instrumental in addressing various crises, assessing student needs, creating safety plans, and providing ongoing support to help students build resilience and increase mental health awareness. Providing this support for our school is a full-time job for our clinician, and not having that access would impede the level of care regarding the number of students and families our clinician can serve, along with building relationships among our school population of over 980 students. Additionally, working with our CBO clinician has enabled us to offer students chances for artistic expression through dance, art creation, and social group activities that strengthen community bonds and promote personal identity growth. Group sessions and classroom visits have allowed our clinician to connect with students and create safe spaces to discuss important mental health issues. Examples like human trafficking, suicide prevention, and substance use, harm reduction, even during a particularly challenging year. To assist our teachers, our CBO clinician regularly consults with the instructional staff to help address student challenges related to mental health, ADHD, grief, and trauma. Teachers have also benefited from quarterly wellness activities, providing time for reflection, movement, and connection with colleagues led by our clinician. Moreover, our CBO clinician has conducted and facilitated professional developments, behavioral mental health leadership meetings, participated in various multidisciplinary team sessions, assisted with impromptu student observations for educational / behavioral impressions, wrote whole school grants, assisted with their school strengthening tool document, and is an intricate part of the school's crisis team. The support from our CBO clinician is truly invaluable as it helps us meet the complex needs of our students and extends essential community resources to students and families. Through our partnership with LAYC, we have been able to offer assistance such as access to the LAYC pantry, guidance with insurance, support for student homelessness, and opportunities for advancement through LAYC events and educational programs. We hope the highest consideration will be made to maintain our partnership with Ms. Asia Felder-Watkins, LAYC therapist, and the Latin American Youth Center. Thank you for listening.
Thank you, Sabrina, for reading that statement, and thank you for your work. And Lupi, thank you for your work and the work of LOAIC, not just on school-based behavioral health, but on all variety of things. I don't have any specific questions for you all. I think everyone sort of pretty covered it pretty strongly, but we're certainly going to ask some questions on Wednesday. This is what I would ask, and I know because I can't say I don't actually know how long the hearing is going to go on Wednesday. We'll kind of see where it goes. We've got a lot of room to cover. A lot of this hearing covered school-based, but there are a lot of other programs that DBH runs that we'll try to get through in terms of the performance pieces. But if there's anything that's sort of said in Wednesday's hearing that you feel is contradictory to what has happened, right? Oftentimes we get this stuff like, oh, we had conversations with stakeholders. Did they? I don't know. We're not always the ones who are also in the room too. But just to help us get clarity about where we're going and how we're moving forward would be super helpful. And, obviously we'll do our best to try to figure out with the mayor's team how to provide some, I don't know, advanced predictability, particularly if the budget is going to be late. This is going to be one of those situations where I don't want folks to end the school year not knowing whether or not they have a job. It's not fair. It wouldn't be fair to teachers. So why would it be fair to the staff who work in the school as well? So we'll do our best. Okay. Thank you.
Thank you.
All right. So we're going to take a 5-minute break. Ashley's going to put 5 minutes on the clock and we'll be right back. Okay. All right, we're back. We're gonna do virtual. So for the folks virtual, you'll need to affirmatively accept our invitation to become a panelist. There'll be a little thing that pops up. We're gonna do panels of 7, kind of see where we go. All right, Carrie Savage from PAVE, Marie Morales Black, Adelaide Robb, Mark Lavoda, Carol Parks, Will Doyle, and Betty Gentle. Righty. Give folks a minute. Same rules apply, 3 minutes. Put your screen on gallery view so you can see the clock. Okay, folks are coming in, but I see Carrie. So Carrie, why don't you go ahead and get started?
Good morning, Chairperson Henderson and members of the Committee on Health and committee staff. My name is Carrie Savage. I'm the Chief of Policy at PAVE, or Parents Amplifying Voices in Education. PAVE is also a member of the Strengthening Families Through Behavioral Health Coalition. PAVE parent leaders have been advocating for stronger school-based mental health support since 2018. The reason is clear. In order for students to show up as their best selves and be ready to learn, we have to take care of their mental health and well-being. Doing so requires thoughtful distribution and coordination of resources and support, with everyone from teachers and school leaders to clinicians and school partners, and of course, families working together. An important part of that collaborative work is adapting and evolving to changing needs and environments along the way. For years, PAVE parent leaders and our partners have advocated for the expansion of the school-based behavioral health program, ensuring funding for at least one clinician in every school. We understand that fiscal constraints and challenges in filling clinician vacancies, we need a different plan, particularly for the short term. We must be realistic about what resources we have available now and work from there, while setting the full-time support at schools as our ultimate North Star for the future. As DBH looks to revise how they approach placing clinicians in schools, I want to elevate what we have heard from both PAVE parent leaders and our partners. First, stabilize high-quality supports that exist in schools. DBH proposals to move all clinicians in-house within such a short time frame risk serious and avoidable disruption to school communities. I echo the concerns my SFC partners have highlighted, including a lack of accurate environmental scan and workforce feasibility. But I will focus on what we've heard from families. Relationships are core to everything, and this is especially outsized for school-based mental health. If there are quality providers that are already embedded in schools, either DBH or a CBO, we should avoid pulling them out entirely. Practically, the shift in the timeline in DBH's proposed plan creates a large gap in the ability to hire DBH clinicians at the start of the next school year. Especially for schools in the top tier of need for support, we should do all we can to retain clinicians within the same school community. This August, we saw how important it is to have a prepared and caring school staff ready to support students on day one, as our political environment in the district continues to present a myriad of threats to our communities. Expansion must mean that schools currently without consistent on-site behavioral support gain reliable access, even if part-time, without destabilizing care in schools that already have trusted clinicians. We strongly encourage a slower phased rollout of the proposal that use all types of providers, accompanied by a published timeline and clear evaluation framework for both DBH and CBOs. Next, we need to meaningfully engage the community in planning for revised tiered service models. I know I'm almost at time, so I'll just name that our partners at the DC Behavioral Health Association have provided an alternative model. I know Mark is here today, and we want to make sure that families and schools have a chance to weigh in. And finally, we ask that we continue to bolster our school-based clinician pipeline and ensure funding for school-based mental health is kept at the same level. Thank you for the opportunity to testify today.
Thank you. Marie? Okay, Marie's not here. Dr. Robb? Okay. Mark?
Hi, Chairperson Henderson and members of the council. Thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illnesses, substance use disorders, or both, including the 35,000 district residents our 35-member organization serve annually. The Department of Behavioral Health's performance in 2025 was one of the worst years since it was established in 2001. Loss of confidence in DBH's leadership is widespread in the provider network and in the broader community. Departures from DBH's leadership team, including its chief operating officer, deputy directors of adult and children's services, and director of provider relations, will further diminish DBH's capabilities. My testimony will focus on DBH governance and oversight of the provider network, clinical criteria for services, and DBH's provider certification process. DBH needs to refocus its efforts on governance and oversight of the provider network. Organizations that faithfully endeavor to provide high-quality care are suffering from a combination of deficiencies in authorization reviews, slow and lapsed local dollar purchase orders and payment processing, and abandonment of consistent local dollar policies and supplemental unit reviews. Meanwhile, DBH has been knowledgeable about pervasive fraud, waste, and abuse for years, but has not taken swift or sufficiently effective action and focused many of its efforts on restricting payment mechanisms rather than removing organizations with evident clinical deficiencies. Management by payment restrictions has proven severely destabilizing for good faith actors, but insufficient to stop bad actors. DBH's approach to updating clinical criteria also has raised serious questions. Clinically documented functional limitations have been treated as an impediment from participation in services. Failure to show progress has been treated as grounds to terminate care. Proposed restrictions go further, with some diagnoses entirely excluded from eligibility for services, without a rationale for exclusion, or even clarity whether some diagnoses would or would not be eligible. DBH also needs to take a new approach to its certification procedures. We have at least 87 provider organizations in the system when the district's total population is 700,000 people. Needlessly, DBH continues to certify more organizations. DBH should be required to provide a plan for network reduction when too many organizations are certified for the same service. More organizations do not result in more access to care, but instead add to the number of organizations unable to meet the full staffing and infrastructure demands that these highly regulated services require to be effectively and efficiently operated. While my verbal remarks focus on the most pressing concerns, my written remarks reinforce that alarm bells should be sounding about the entire operation of the Department of Behavioral Health. DCBHA stands prepared to partner and search for solutions. Thank you for the opportunity to testify today. I look forward to answering any questions you may have.
Thanks, Mark. Carol Parks. Will Doyle.
Can you hear me?
Oh, there's Carol.
I am
Yes.
here.
All right, we can hear you. Go ahead.
All right. Good morning, Council Henderson and other council members. My name is Carol Parks. I'm the Chief Executive Officer of Hillcrest Children and Family Center. Hillcrest just recently celebrated 210 years of services to the community, DC. We're very fortunate to be able to have such a stabilized organization. I wanted to speak about a couple items that's been mentioned earlier, but my partners and collaborators have spent a lot of time talking about the comprehensive plan for school-based behavioral health. We support working with Dr. Bazran and her team around school-based programming and others. The goal of ensuring that every school has access to behavioral health support is both timely and necessary. However, based upon the up-to-date information presented by DBH at the Coordinating Council, the goal of reaching all CBOs being able to provide services is very close. There's only 2 CBO vacancies. Hillcrest has 1 vacancy for 25 DBH grant funded staff. This is due to DBH's being providing us the necessary financial resources this year. We believe that there's evidence that we're on the right track. I testified back in November 5th at the roundtable about my concern with DBH planning to eliminate CBOs over the next 2 school years, and I share the same concern. That hasn't changed. While DBH has provided in listening sessions, met with school leadership, and continued meetings with CBOs, however, as of today, DBH is still moving forward with their initial plan. Based upon reviewing their response to your questions, it looks like they are planning to follow up this month with schools and other providers around this issue. The DCBHA, which Mr. Levita just spoke about, has offered a plan that we believe would move forward. It would allow for additional uniformity around metrics for providers and make sure that CBOs are held accountable, similar to DBH, for our performance. We see this as our commitment to offering solutions to allow continued continuity of CBOs as well as decreased disruption to school children and parents. Based upon school needs, of course, we should look at what's best. And we believe that there's evidence that once the environmental scan has been done correctly, that you'll see that we can create a diverse population for services. I believe also I would like to transition to another issue quickly since I only have 30 seconds. DBH has a lot of pressures already in front of them, such as dealing with Medicaid reform, making sure that they're paying providers on time, which we are still waiting for funds from September, the community support authorization issues, as well as we hope that DBH will spend more time with DC Healthcare Finance about exploring CCBHC model, which we believe that will help with integration of care. Thank you so much for giving me the opportunity to present at this moment.
Thank you. Mr. Doyle?
Thank you, Chair Henderson, council members, and council staff. My name is Will Doyle, and I'm the Vice President of Housing First, Pathways to Housing DC. We deeply appreciate the continued funding and support we've received for the Court Urgent Care Clinic, despite immense budget pressures to eliminate it. As a result, our staff have continued to provide immediate access to mental health and substance use assessment and treatment at the DC Superior Court. In FY25, staff completed 897 unique intakes, which is 50% above our contract benchmark of 600 and 29% more than in FY24. Additionally, we conducted 1,078 assessments and 5,747 follow-up visits. In FY26, staff are on pace to complete 1,112 unique intakes, which is 85% above our contract benchmark and 24% more than in FY25. We are also on pace to complete 1,444 assessments and 6,344 follow-up visits. This exponential growth illustrates the ongoing and increasing need for this critical same-day behavioral health service. DC's funding of this program has been crucial in being able to provide urgently needed services regardless of client identification, insurance, or residency status. As we shift into budget decisions for FY27, we urge DBH and the Committee on Health to continue prioritizing funding for the Court Urgent Care Clinic. I want to speak about one specific area of concern, that is in regard to individuals who need medical clearance when involuntarily hospitalized. Given our work with individuals who are chronically homeless and experiencing serious and persistent mental illness, this is a common occurrence. Currently, CPAP is not equipped to manage this on site. Instead, individuals are sent to local hospitals. When that happens, we typically see significant delays and discharges instead of returning to CPAP and getting the mental health stabilization that they need. This makes involuntary hospitalization an ineffective intervention and prevents us from addressing underlying issues and negative impacts on the community. This is especially a challenge with clients who are frequently visiting local hospitals. To address this issue and ensure all involuntarily hospitalized individuals receive appropriate interventions, we strongly urge CPAP to be staffed with a nurse practitioner, like is done at the Stabilization Center. Thank you for holding this hearing. I'm happy to answer any questions.
Thank you. Betty? Okay, Betty's not there, but Dr. Robb has joined us.
Yes, technologic issues. Good morning, Chairperson Henderson and members of the committee. My name is Dr. Adelaide Robb, and I serve as the Chief of Psychiatry at Children's National Hospital. For over 150 years, Children's National has been an integral part of the healthcare safety net serving children and families in Washington, D.C. and the metropolitan region. Thank you for the opportunity to provide testimony on the FY 25-26 performance at the Department of Behavioral Health. As a top children's hospital in the nation, as published by U.S. News & World Report Best Survey, Children's National Hospital is deeply invested in the mental health and well-being of children, youth, and families in the District of Columbia. This commitment spans inpatient, outpatient, and community-based systemic efforts, some of which I will touch upon today. We are proud to partner with DBH on several initiatives, including efforts to expand access to substance use disorder services for children and adolescents across the district. Through the opioid abatement grant, first funded by DBH in March 2024, Children's National has been able to provide comprehensive evidence-based care to young people experiencing substance disorders. Since the project's inception, we have been able to grow and deliver care to an increasing number of patients, including approximately 60 youth in 2025. Funding has supported the hiring of a pediatrician who is board certified in addiction medicine, a psychiatric nurse practitioner, and 2 peer recovery specialists, enabling the clinic to expand operations from 3 to 5 days a week. In addition to increasing clinic volume, we have increased our reach and helped reduce distance-based barriers to care for youth in wards 7 and 8 by opening clinic sites at the ARC and Shaw locations. We are proud to report that we have not experienced any issues this past year and work collaboratively with DBH to discuss progress, challenges, and opportunities to expand. While we are encouraged by the progress we have made in substance use disorder, we recognize there is still work to be done to strengthen the full continuum of care for children and adolescents. We continue to see the need for intermediate levels of care, as well as the continued need to connect children and families to high-quality, community-based care in a timely fashion. It is crucial that our city has enough options available, such as partial hospitalization programs, that help children and adolescents before they reach a level of severity that requires admission to inpatient care. We look forward to collaborating with DBH to advance solutions to better serve our youth and to improve their behavioral health outcomes. Children's National Hospital is pleased to be an active partner in the ongoing work of the Department of Behavioral Health's development of a strategic plan for children's mental health. We are optimistic that this strategic plan will continue the realization of an integrated, full, and robust continuum of care, helping to ensure high-quality, accessible, and reliable psychiatry and therapy services, and look forward to its proposed strategies being applied to DBH governance meaningfully. I appreciate the opportunity to testify today and would be happy to answer any questions you or the committee may have. Thank you.
Thank you. Thank you to this panel of witnesses. Dr. Rob, I'll start with you. Some of the data that we received from DBH in the pre-hearing responses was quite alarming in terms of, in some ways, it feels like we're trending upwards in terms of the number of youth who are needing to seek care for substance use disorder. According to the data in the first quarter of fiscal year 26, children served 22 youth, which is almost the entire number of young people that was served in fiscal year 25 altogether. Obviously, we need to do more in terms of broadening the number of slots available for young people seeking treatment. But is there something else that we should be doing from a public health PSA approach standpoint to educate parents or even just young people about the risks?
So I think there have been a number of opportunities that Dr. Kelly Murphy and Dr. Thakor and the rest of the team who see patients have been involved in, including community conversations and helping youth. We also are doing more screening for substance use at
Dr. Rob? Dr. Rob, did we lose you? Okay, I think we lost her. So we'll come back. Mr. Parks, if you're still there, you mentioned in your testimony that you all were still waiting on funds for services provided in September. Can you say more about that?
Yes, DBH has what's called local dollars for purchase orders. Hillcrest and some other providers as well, I believe, have not been paid for rent services rendered since the new fiscal year started on October. We've been in contact with DBH, and they've assured us that it's went to the CFO's office or OCP, but as of to date, we still have not been paid, and we've continued to render services because we don't believe in turning people away, but it does have an obviously impact on agencies from a cash flow perspective.
Oh, sure, for sure. I mean, it's been, several months at this point. Can you be
Mhm.
more specific in terms of which services so we can know how to follow up?
Well, there are local dollars, which are based upon, we provide a full array of services, whether it's diagnostic assessments, individual group therapy, med management. It's a full array of what's called MHRS services.
Okay, that's what
That
I was saying. It was
mhm.
MHRS. I was just looking for
But
that
for
specific.
the local dollars, that's the ones that individuals don't have insurance at that moment, which is another issue I
Councilmember
mentioned
Henderson.
earlier about the impact on Medicaid and or the lack of insurance for some of those high need clients that we all serve.
Okay.
Mhm.
Councilmember Henderson, if I can just add, this is
Oh,
a pervasive concern across the provider network right now. There are
okay.
multiple MHRS providers, multiple CRF operators. I believe there might be some of the substance use providers that also still don't have local dollar purchase orders, or they were given a local dollar purchase order that has already expired. I know organizations that got purchase orders that only extended to January the 31st. So we really need effort to get this corrected.
Yeah, I mean, well, we heard testimony at the beginning of this hearing about a number of CRFs who were deciding to close. I'm sure some of this could be around um, lack of consistency in terms of payment. And I will ask what's going on here. I mean, the money exists, right? And the money has been loaded since October. So why contractors haven't been paid since, that time is a bit bewildering, but thank you all for bringing this to our attention so we can certainly follow up on that. Mark, while you're here with us, I wanted to ask, it seemed like from your testimony, you covered a lot of different issues, but one of the things you also talked about, or at least what I heard, is that you believe there are too many organizations that are certified, um, which is kind of the opposite of what I've heard, but I'll give you opportunity to say more.
Yeah, I do think that there are too many organizations that are certified. The last count we have is that there are 87 certified. It sounded like from some conversations we've had with DBH staff, there are several more that are scheduled to be certified this week. Um, it really just doesn't make sense given the complexity of operating these services and the scale that's needed to do this work effectively to keep adding organizations. I'm not saying that we don't need frontline staff. Absolutely, we need people to be delivering services to meet the need of consumers in the district. But the number of organizations is actually making it harder for DBH to keep track of performance, as we've seen with the fraud, waste, and abuse, and as we've seen from access to care issues and clinical quality issues. And I think that it really is time for a reset in terms of how DBH governs and has oversight over the provider network. And part of that is the provider network is just far too large.
Okay, that's helpful. I mean, I'm always sort of surprised when they're like, "Oh, we have all of these organizations that want to be certified and come on." And then all of these organizations also somehow have all of this high quality workforce. Meanwhile, I have other organizations who are telling me that they have workforce shortages. So I'm like, "Okay, well, how is everybody starting their own business and actually having certified individuals who are competent to provide care?"
And they're
Um,
not. I mean, that's the bottom line is
yeah.
that they are not hiring the individuals that they need to do that work correctly, and in some cases, not at all.
Yeah, we last week we had the oversight hearing for Department of Healthcare Finance, and we spent a lot of time talking about quality investigations and fraud. And across the health cluster, the biggest amount of Medicaid fraud is coming out of behavioral health. And so we were talking about what are some of the strategies and ways in which we need to sort of deal with this. But now I understand some of the connection that you're bringing to that
Yeah,
conversation.
and I listened to that conversation. And I do think that addressing the fraud, waste, and abuse explicitly is important, and DHCF has, in many ways, the lead role there. But we also need DBH to exercise its clinical judgment and say that these organizations just are not behaving appropriately. We don't have to wait to prove fraud, waste, or abuse
Yeah.
when people can't get the access to the care that they need or care is not being delivered with the level of quality that it should.
No, I agree with you on that. If we're getting to the point of just waiting on Medicaid fraud, what about whether or not somebody actually health improved? Were they seen? Was it good? All of those different things. So thank you. Thank you for being here. Thank you so much to this panel of witnesses. I don't have any further questions for this group. We're going to go on to the next group of 7. Nadia Casey, Carla Reed Witt, Chioma Aru, Sahara Fernandez, Hillary Kaser, Laura Mistis, DC Prep. Jamila wanted to go later. And Gracie Obuchunowicz. Let's see who's here. All right. Again, you'll need to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up. I'm trying to give it a minute. All right. Is Nadia with us? No. Okay. Okay. Nadia, we'll let you in. Or okay. Is Carla already in? So
I'm here.
Carla. Okay, great. Why don't you go ahead and get started?
All right. Hello, Chairman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Carla Reed Witt. I'm a DC resident, deeply engaged in children's behavioral health, family advocacy, and system design. I'm here to address the critical and longstanding gap in our pediatric behavioral health continuum of care. DC does not have much needed pediatric partial hospitalization, PHP, and intensive outpatient IOP programs within the city limits. These services are foundational. We have been trying for a number of years to create a successful school-based behavioral health program. In fact, DBH is ready to throw out the current model and implement a new one. The critical flaw with the current model is not just our failure to provide grants large enough to allow CBOs to pay market rates sufficient to be competitive, or anything CBOs and DBH did or did not do. Even if all the stars aligned, our school-based behavioral health system will never be successful unless DC has a robust pediatric behavioral health continuum. Like similar cities across the country, DC is facing a youth mental health crisis. Of the 12,436 DC middle schoolers surveyed, over 1,500 reported that they had tried to kill themselves. We have a lot of kids with serious needs and no way to provide sustained support. Right now, kids with intensive needs cycle in and out of crisis care in the juvenile justice system. Without step-down intensive pediatric mental health services, schools must absorb intense needs they are not resourced to manage and must lean on school-based mental health programs ill-equipped to provide that level of support. PHPs and IOPs serve students needing more than weekly therapy, but less than inpatient and residential treatment. They are the mid-level interventions that provide essential step-down support for youth moving out of restrictive mental health environments and back to family, school, and community. DC's lack of PHPs and IOPs results in higher numbers of residential placements, inpatient stays, ER visits. It also results in increased school disruptions, missed instruction, absenteeism, suspensions, and interaction with the juvenile justice system. Prior intensive service programs failed due to improper program structure and deficits in economic support. Our efforts must include incentivizing provider development and sustainability through braided funding, rate adjustments, startup support, and private insurance buy-in. Without appropriate services located within DC, all but a few students must travel an hour outside of the city, forcing them to choose between their education and the mental health services they desperately need. I urge the council to prioritize the creation of pediatric PHP and IOP programs within the district and hold agencies accountable for building a complete pediatric behavioral health continuum of care. Thank you for your attention and your commitment to the well-being of DC's children. I welcome the opportunity to support this work in any way that's helpful.
Thank you. Nadia?
Yes, good morning or good afternoon, all. I want to introduce myself as Dr. Nadia Casey. I am with Gardenzia Rapp as the Regional Executive Director. Thank you so much, Chairperson Henderson and members of the Committee on Health, and thank you for holding today's performance oversight hearing for the Department of Behavioral Health. I am honored to testify on behalf of RAP, which has provided a full continuum of services for more than 50 years, from crisis stabilization all the way through outpatient and intensive outpatient. RAP sincerely appreciates the Department of Behavioral Health, Dr. Bazaran, Phyllis Jones, and their entire team for their exceptional leadership and steadfast partnership in responding to the opioid crisis. We are deeply grateful for DBH's recent award of opioid abatement funding to RAP, which reflects the district's commitment to expanding access to high-quality treatment for residents struggling with substance abuse disorder. While the opioid abatement funding provides meaningful and much needed support, it exists within a broader system where ongoing reimbursement challenges continue to constrain provider capacity, which you've heard so much today. Despite continued demand for residential SUD treatment and the critical role these services play in supporting recovery, the district reimbursement rates have not kept pace with the cost of providing that care. The rates for residential SUD services have not been meaningfully adjusted for many years, despite rising staffing, clinical, and operation costs. This misalignment is particularly challenging for providers delivering low acuity step-down services, which are essential to maintaining recovery and preventing relapse, but they are also the most difficult to sustain financially. Independent of inflammatory pressures, Medicaid reimbursement rates for residential SUD services in the district have fallen substantially below those peers, including those in Maryland and Virginia, which jeopardizes our ability to sustain and serve in a quality way. For example, the per diem rate for level 3.1 in the district is $128 per day compared to $179.13 in Maryland and $196.88 in Virginia. That varies, that we are 40 to 60% paid less than our local counterparts. Chairperson Henderson, thank you for the opportunity to testify today. We are asking for your support in ensuring that SUD residential and outpatient service providers are able to provide the services that our residents so greatly need. Thank you.
Thank you. Chioma? Sahira Fernandez?
Okay. Good afternoon, Chairperson. I'm Saida Fernandez Stepanczyk, a Ward 7 resident, the Chief of Student Support and Engagement at the Next Step Public Charter School, and a licensed independent clinical social worker. I'm here today to share my experience supporting students with mental health needs and raise concerns regarding the Department of Behavioral Health's comprehensive plan. Founded in 1996, the Next Step Public Charter School was established to serve young people and adults who have faced barriers in traditional high school settings. Many of our students navigate complex challenges. For our students, the mental health supports provided at our school are not supplemental, they are essential. Some students rely on these services to remain engaged, stable, and enrolled. Our school social worker provides individual and group therapy, facilitates workshops for both students and staff, supports students with individualized education plans, and responds to mental health crises as they arise. We also maintain a partnership with the University of Maryland, Baltimore School of Social Work, through which graduate social work students complete their internships at TNS. This partnership has been especially critical during periods when we have been unable to recruit a bilingual clinician to meet the needs of our student population. While I appreciate DBH's efforts to develop a comprehensive plan, I have concerns about both the proposed model and its implementation. The plan would spread the same number of clinicians across more schools, reducing in-person presence and increasing reliance on telehealth. This approach runs counter to both research and my experience, which shows that embedded in-person mental health supports are most effective in building trust and improving student outcomes. Additionally, the environmental scan process that informed the comprehensive plan itself was confusing. I completed the survey for my school without realizing that the feedback I shared would inform a broader redesign of the service delivery model. My recommendations for strengthening implementation include the following: increased transparency and clarity around future surveys, including how feedback will be used and the potential impact on service delivery models. Allow schools to retain community-based providers that have demonstrated success delivering effective, trusted mental health supports. Ensure schools are given adequate time, guidance, and technical support to implement any new or required changes. When I served as the strengthening plan coordinator at the Next Step, our assigned expansion clinical specialist was accessible, responsive, and provided clarity on plan requirements. That level of support should be consistent and available to all schools during their transition or implementation process. We should also continue to invest in growing the clinician pipeline and address clinical vacancies through licensure reciprocity. I urge you to carefully consider how any proposed changes will affect both student service delivery and schools' capacity to support them. We must be mindful not to introduce additional administrative burdens or structural barriers that make it harder for clinicians to deliver timely, effective mental health care to our students. Thank you.
Thank you. Laura?
Hi, sorry about that. I was just trying to get off mute. All right. Good morning, Chairperson Henderson, members of the council and staff. My name is Laura Maestas, and I am the CEO of DC Prep, a public charter school network serving more than 2,100 students across 6 schools in wards 5, 7, and 8. I'm here because DC has made an important commitment, ensuring that the students who need access to mental health professionals have access to mental health professionals in their schools. That commitment exists on paper, but in practice, DC does not yet have a viable plan to ensure that those clinicians actually exist. All 6 DC Prep campuses are eligible for a DBH-funded clinician. Today, we have 2 DBH-funded clinicians placed through community-based organizations and 1 DBH-employed clinician who is expected to split time across 2 of our schools. That means that 2 of our campuses serving some of the city's highest need students still do not have a dedicated DBH clinician, and 2 of our campuses, each of which could absolutely benefit from a full-time DBH clinician, only have a part-time clinician. This is not because schools don't want clinicians. It's not because community-based organizations aren't trying. It's because DC does not, to my knowledge, have a pipeline strategy to ensure that the clinicians exist. Over the last several years, DBH's reimbursement rate for clinicians has increased significantly, but the overall funding for the program did not increase. That resulted in DBH now being able to afford fewer clinicians than before. At the same time, CBOs are unable to fill many of the positions that technically exist. So we're stuck with a system where schools were told that we could have access to DBH-funded clinicians. DBH does not have the budget to fund enough clinicians for all the schools who are eligible, and there is no alternative mechanism to let schools use dollars that have been allocated to solve the problem themselves. There is a bottleneck. At DC Prep, we decided not to wait. We partnered with Momentum to host early career clinicians and strengthen their on-the-job support and retention. We used grant dollars to send 3 of our own teachers, women of color who already know our students, to earn clinical degrees with a commitment to serve in our schools after graduation. As a result, all of our school-funded clinical roles are now filled, and we would be able to hire 3 additional clinicians, the teachers that I just mentioned, over the next 6 to 18 months if we had available funding. And that's the rub. We've been told that we should not plan to receive the funding allocated for our schools to have a DBH clinician. If schools like DC Prep could receive the funding directly under clear guardrails, we could hire our own clinicians, build supervision and training structures, expand partnerships with universities and fellowship programs, and grow DC's future workforce of school-based clinicians. That's how we could build a pipeline together. Right now, the district is effectively saying we only fund clinicians if someone else hires them first. And in the middle of a national shortage, that just doesn't make sense. So my request to the council is very straightforward. Direct DBH to develop and fund a real clinician pipeline strategy for schools, one that includes direct LEA funding options, early notification of allocations, and investments in training, supervision, and grow your own pathways. Our students can't wait for the clinician pipeline to fix itself. Thank you.
Thank you. Gracie?
Good morning or good afternoon, Chairperson Henderson, members of the council and staff. My name is Gracie Abahovich, Director of Educator Wellness for Empower Ed. A few months ago, I testified against DBH's proposed comprehensive school behavioral health plan, critiquing its failure to address educator well-being, its top-down design, and its exclusion of teacher and community voice. Today, I return to emphasize that while placing qualified clinicians in schools is necessary, it is also insufficient. We lack a systemic, holistic vision for our students, teachers, and schools. In the wake of COVID and the ongoing challenges of our cities faces, families are struggling. Schools must become true safe haven for students to receive integrated emotional, mental, and academic support to thrive. We can examine the shortcoming from many angles, but as someone who supports DC teachers daily, I must discuss it from their perspective. One of the most consistent and distressing themes I hear from both teachers and administrators is the crushing weight of unaddressed student mental and behavioral health needs. DBH's systemic inaction is not a neutral fact. It actively transfers this crisis onto the backs of educators, adding to an overwhelming workloads and accelerating burnout. We are losing caring, committed adults from classrooms at the very moment our students need them the most. This brings me to the inseparable two-pronged nature of teacher wellness. First, we must support teacher wellness and improve workplace conditions so they can sustainably stay in their careers. Second, we must effectively support student mental health so teachers can do what they do best, teach. Currently, DBH is failing at both. They do not seem to understand that you cannot foster healthy students in buildings filled with distressed adults, nor that student support must be designed to lift burdens from educators, not to add to them. Therefore, my urgent request is teacher perspective and voice must be centrally reflected in any strategic planning for student well-being. Teachers spend all day with students. They know their needs. They see where the system fails them. This cannot be a single survey or advisory panel. I urge the council to direct DBH to first convene a series of paid teacher listening sessions and focus groups, compensate educators for their time and professional insight as we would do any other expert consultant. And second, require DBH leadership and planners to complete a meaningful number of hours observing in classrooms across all 8 wards to see the reality of unmet needs and how their systems currently add to teacher workload. Please ask teachers to solve these complex problems, but also beware, do not let this become one more poorly planned top-down initiative that, however well-intentioned, becomes an unfunded mandate that adds to their workload and drives them out. Teachers are the first responders and the experts. We must build solutions with them, not for them. Any real plan must support the whole school community, students and the adults that serve them. I'm available to answer any additional questions. Thank you for your time.
Thank you. Thank you to this panel of witnesses for your testimony on a variety of different things. Laura, I wanted to start with you, if possible. What you suggested in terms of providing LEAs with the funding and allowing them to hire clinicians. We tried that. We had to push DBH to start that pilot. And that first year, we did have a number of charter LEAs who, applied for that funding, was successful in doing so. But then it waned, and this school year, we don't have anyone. So curious, like did DC Prep attempt to do this the first time? And, were there pitfalls to that particular pilot?
It's a great question. And I will say I have been asking for this for several years, like long before the program launched. I've been advocating for this with the deputy mayor's office because I think that it is such an important part of the solution. Because I think, as Gracie was describing, schools face this challenge with the mental health needs of students, regardless of whether or not we have a clinician from DBH. And so we need the funding to be able to make sure that we're addressing that in the best way possible. I was told that DC Prep was not eligible to participate in the pilot. I don't really understand why. The first time around, because I think the pilot has gone on for 2 years. The first time around, I was told that our vacancies hadn't existed for long enough or something along those lines, even though we had basically I could share all the detail, but we've had very long-standing vacancies in our DBH funded positions. And then the second year, I tried to start advocating early to be able to get access to the pilot, and I was told that we couldn't join. I was never given a rationale. So it's really disappointing to hear that it's like not an option because of like lack of interest or it waning, because I would die of happiness if we were able to participate in that program. We've got the clinicians, like I said, we have 2 teachers who will be graduating this spring, so we could make it happen like immediately. I just need confirmation that we have the funding available.
Okay. That's helpful to know, and we could certainly follow up on that because, again, I'd heard from a bunch of charter leaders who desire this. It took us a while to get DBH to finally do it. We did, and year 1, okay, and then now they're saying, oh, no one applied for this current school year, and so, yeah. Yes, Laura, I see you.
I wonder, I'm not sure, I wonder whether part of the issue is timing. So in order for me to be able to like say to you that I'm going to have, a clinician available on staff, by the start of the school year, I need to start making decisions like in February in order to be able to execute appropriately. I wonder if part of the issue might have been the timing of when funding was confirmed. But I don't know. That would be one of the questions that I would ask, though.
Okay. We can certainly follow up on that front, but thank you for being here and thank you for your testimony. Nadia, or excuse me, Dr. Case, I wanted to ask if some of the information that you provided around the rates for residential SUD is certainly fairly stark. One of the things we have often seen is that, right, we have a number of treatment facilities that will locate sort of on the border of Maryland and DC, or on the border of Virginia and DC, because while DC would be willing to send patients to Maryland or to Virginia, those jurisdictions often are not willing to send their patients to DC. And so it's sort of like they get to benefit from best of both worlds, getting DC to send people, but also because they're based in Maryland, they can still benefit from that. But I don't like to send our people out. And so one of the questions I had always been asking is around, when we conduct rate studies, are we actually doing it from a regional perspective to determine whether or not we're being competitive? And, from the information you shared in your testimony, Maryland and Virginia are paying, 40 to 60% more than what we are. I suspect that would make it very difficult for somebody to continue to operate in the district when Maryland and Virginia are offering more money. I don't know if you wanted to say more about that.
Yes, ma'am, you are absolutely correct. And so that I think leads to a lot of other elements as well, even when we're talking about recruiting and retaining staffing, right? Because they're able to, even though the cost of living is higher in DC, they're able to pay more because of their reimbursement rates are higher. We only have 4 residential providers in the district. And so we are working very, very hard to be able to serve those folks. The rates are just not comparable, right? If you think about it, even just all of the requirements of providing food and shelter and all the other health needs that we must provide for our population, we are absolutely struggling. It also impacts, in listening to what some of the others are talking about in terms of outpatient PHP, the residential rates also negatively impact our ability to do a step down. Because of course we are not able, or really struggling hard to sustain ourselves. So it is significantly impactful, especially for the population that we serve.
Okay. Thank you for being here. Thank you to this panel of witnesses. I don't have any further questions. If you haven't provided your testimony for the record, please do so. We're going to go to, okay, well, she'll go on the next panel. So we're going to go to the next panel. Hillary Kaser, Sharon Goods.
Hi, I'm here.
Oh, just hang on, Hillary.
Work. Thank you.
Hang on one second. Shane Sullivan, John Smith, Patrice Turner, Ruth Pollard, and Shannon Walsh. Okay, just as a reminder again, you'll need to affirmatively accept our invitation to become a panelist. Okay, Hillary, when you're ready.
Great. Thank you so very much. And let me just say thank you so much to your staff, the committee staff, because my technical challenges with joining have been enormous, and their support has been really much appreciated. And I also want to thank you, Councilmember Henderson and Committee Chair, for a year ago. And because I'm having problems with the tech, I don't have in front of me the transcript. But as you referenced at the end of your live witnesses today, your hearing with Dr. Bazran will, went for 4 hours last year. And at the very end, you mentioned what everybody knows I'm coming to talk to you about today. But nobody wants to talk about, and nobody wants to deal with, certainly not at DBH. And you got Dr. Bazran to say that it mattered. And I don't have the transcript in front of me, but I will put it in the written testimony. But we're still here with a problem defined over 13 years ago now as hoarding disorder, HOARD, hoarding, clutter. And nobody wants to talk about it because there's still so much shame, stigma, and judgment. When I first started testifying this committee a decade ago, I was talking about peer support. This committee did this amazing report, which I will reference in the written testimony, when you had that wonderful temporary staffer, Naya Koch. Your committee had your own conclusions about the problems with hoarding in our community. There's a United States Senate report saying this is a looming problem nationwide. It's been in the national news. It's been great and gratifying to hear so many witnesses today talking about issues for youth. Research says that hoarding disorder presents in adolescence, as young as 11 years old. Who do we have to FOIA to find out how much it's costing to put older people who have gone with no services for decades and have been allowed to reach a crisis triage state, to putting them under guardianship and into nursing homes because of the hoarding disorder, because there was no early intervention? Here's another possible reference, is a book called Digging Out, and I will put that reference in the written testimony too. But that book is great because it focuses on harm reduction. And finally, let me just say that the Fairfax Hoarding Committee, we have these hoarding things around our region, but what do we have here? They are now convening a region-wide thing that they're calling Meeting of the Minds. It would be amazing if somebody from DC, other than myself, were to participate in that regional thing. I will put that in the written testimony. That I think is March the 12th. Thank you very much. I appreciate the time, and please ask questions.
Thank you. Sharon? Sharon Goods? Sharon, if you're speaking, you're on mute.
Thank you. Good afternoon. I appreciate the opportunity to come before today, Chairperson Henderson and members of the Committee on Health. My name is Sharon R. Goods, and I am a longtime district resident and business owner. I'm the principal of 3601 14th Street LLC, which constructed, owns, and operates a 10-unit apartment building at 3601 14th Street Northwest. I'm here today regarding the District of Columbia's Department of Behavioral Health's $3.5 million fixed price contract with vendor NBI Health Services, LLC, contract CW 104624 for mental health services, including permanent supportive housing. Permanent supportive housing is built on a housing first model, which rightly prioritizes access to stable housing without preconditions such as sobriety or treatment compliance. The goal is to stabilize lives by pairing housing with voluntary supportive services that build independent living and tenancy skills, and connect participants to healthcare, treatment, and employment. Since one of the company, NBI Health Services, has one of their clients in our building since July of 2025, and we leased apartment to client number T 10-00. Since that placement, our property has experienced a level of disruptive activity that has rendered this award-winning building unsafe for fellow tenants, the women and children who reside there, some of whom are also MBI Health Services clients. Security footage shows that tenant 00 admitting more than 10 unsupervised individuals nightly into the building, sometimes with scooters and bikes, and sometimes always with backpacks and bags. Our security guards, video footage, tenants, and 5 MPD police reports document individuals sleeping in the hallways, loud and unruly altercations, a woman beaten badly enough to require hospitalization, threatening of 6-year-old female tenants by the tenant T00. We've witnessed him scaling our wrought iron rear fence, stretched out on the floor in the public hallway, engaging in conflict with fellow tenants. There's a legal and moral distinction between supporting individuals with mental health issues and tolerating the exploitation of vulnerable people. Multiple individuals associated with the tenant state that he's charging them money for services and for keeping their stuff. Women have been observed escorting multiple men in and out of the building at all hours of the night. This activity disrupts our residents' lives and places them at risk. The conduct destroys tenants' rights to a peaceful enjoyment of their homes, and it's prompted our special police officers and MPB to issue more than 5 police reports regarding this guy's activities, and we've already filed for eviction. Each incident was reported to MBI Health Services. Instead of escalating these reports as required under the duty of care, MBI staff has been dismissive and reframed the alleged criminal conduct as behavioral health issues. Rather than initiate investigations, impose conditions or remove a client engaged in alleged predatory conduct, MBI has focused on preserving its performance numbers. On the District of Columbia procurement law and DBH's own contract management obligations, this level of document harm should trigger both formal incident review, performance investigation, corrective action plans, and potential contract sanctions. To my knowledge, none of this has occurred.
Ms. Goods, I'm so sorry. I know you're on your phone, so you can't see that. You're about a minute over your time.
Okay. Thank you so much. I appreciate your time, and I'm taking any questions that you have regarding this incident.
All right. Thank you. Shane?
Hi, good afternoon.
There you are.
Hello, my name is Shane Sullivan. My pronouns are they, them, and I'm a Ward 4 resident and member of the National Survivors Union, a National Drug Users Union that broadly advocates for policies that promote drug user health and support an end to the weaponization of drugs, as well as the people who use and sell them, as a justification for expanding the carceral state that acts within the broader apparatus of racial capitalism. This is an especially vital task in DC, where an 85% of overdose deaths consistently occur among Black residents, and over 90% of drug convictions are also of Black residents. DC has also experienced an overdose crisis for years, although we've witnessed a drop-off in overdose deaths since their peak in 2023. In addition to NSU, I was an outreach worker with HIPS for over a decade and co-founded Decrim Poverty DC, a coalition of community-based groups. When most active, we were specifically focused on introducing and passing legislation in the council to decriminalize drugs and to establish 2 24-hour harm reduction centers in DC. I've been really disappointed to see our ask around that co-opted in order to establish sobering centers. And I know that there's a second sobering center that's supposed to be established in Columbia Heights relatively soon. Decades of research shows that harm reduction works and does not show that sobering centers do more than divert calls regarding things like alcohol intoxication from the ER. And there is a lot of money being poured into that. And what I've heard is that there is not the political will to open a 24-hour harm reduction center. And while I do support a theoretical center having a safe consumption component, even without that, we still need to invest in harm reduction funding, especially under this federal regime. And it would still allow for drug checking services and full wraparound care that currently we're not able to provide. I just want to point out too that the overdose crisis is actually an issue of market regulation, and prohibition creates the conditions for the volatile street supply. So historically, pretty much every class of drug that is criminalized was not criminalized out of concern for the well-being or safety of the public, but rather rooted in racism and xenophobia. And lastly, overdose, while on the decline, is still very much a vital issue to comprehensively address. My former colleague and close friend, Jessica Martinez, died by overdose last September. She was a proud trans Latinx sex worker, drug user, and brilliant harm reductionist who advocated for the decriminalization of both sex work and drug use before this very council. I know I'm out of time, and I tried to time this so that I could have the last few seconds of my remaining time as a moment of silence to honor her memory. So just offering that. Thank you.
Thank you, Shane. Thank you. Dawn? Okay. Catrice Turner?
All right, good afternoon, Councilmember Henderson. My name is Catrice Turner. I'm a native Washingtonian, current Ward 5 resident, and I serve as a PAVE citywide board member. Additionally, I'm a bonus mom, teacher, counselor, confidant to the hundreds of students and families I serve under my role as Chief of Family and Community Engagement at Monument Academy Public Charter School. But for those that know me, my favorite role is that of mom to my 4 boys, TJ, Justin, who both attend McKinley Tech, and Devin and Carter, who's at Minor Elementary. I'm here today as a parent deeply committed to the academic success and well-being of my children, and specifically to advocate for strengthened school-based mental health and academic supports, especially for students who are chronically ill or receive special education services. My family's experience underscores how urgent this need is. Justin, who's the second of my brood, he's 15, was recently diagnosed with a serious medical condition, APOL1 mediated kidney disease. So this past year has been full of impromptu hospitalizations. He currently undergoes 2 days a week, 6-hour outpatients infusions, which I'm sure, as you can imagine, is incredibly frustrating for a high school freshman who should be having the time of his life. But at the same time, my other sons have been emotionally overwhelmed. TJ, my eldest, who is also at McKinley with him, has been caught taking lengthy routes to his classes to check for his brother in his classes, because sometimes Justin cannot even make it through an entire school day and is dismissed or sent to the hospital without TJ being made aware. Carter, my 6-year-old, recently, while participating in class discussion, told his classmate that his brother is going to die soon, causing quite the commotion among the students and staff in the kindergarten wing. Devin, my 8-year-old, kicks, screams, and cries many mornings going into school because he's fearful that when he gets home, his brother won't be there because something has happened to cause him to be rushed to the hospital. This is all a lot for any child to manage, and a lot for their classroom staff to attempt to support while teaching. Unfortunately, access to timely school-based mental health services for them has been extremely challenging for my other 3 sons, because they aren't the ill people, or they're not the students with the IEP or 504 plans. But overall, each of my boys have taken a hit. It is critical that we expand access to school-based mental health clinicians so that any student seeking support can access it. I worry how changes to the implementation of the school-based mental health program could lead to a decrease in access to clinicians, making it even harder for our children to access the support that they need. These realities compel me to request that from you, if you could, 1, ensure funding for school-based mental health programs that is maintained. In a tough budget year, we still must protect our most vulnerable students by continuing to fund the services that they need. 2, restore CHAMPS funding to fiscal year 25 levels. CHAMPS faced serious cuts this year, reducing access to quality youth-focused crisis response. And I've used CHAMPS several times between work and with my boys as well. And lastly, get creative with access to clinicians in schools. We all know that the budget climate is looking bleak, but there's so many wonderful community members willing to assist with this endeavors. I appreciate you for your time and look forward to any questions you may have.
Thank you, Catrice. Ruth?
Hi.
Good afternoon, Chairperson Henderson and Committee on Health members. My name is Ruth Pollard, President and CEO of the DC Primary Care Association. Thank you for the opportunity to testify about oversight of DBH. Our health centers are on the front lines of delivering comprehensive, integrated primary and behavioral health care, especially for residents facing the greatest barriers to access. In 2024, DCPCA member health centers served almost 20,000 mental health patients and 5,400 patients with substance use disorder through more than 90,000 inpatient visits and over 62,000 virtual visits, demonstrating both the scale of demand and the importance of telehealth as a core access point. As reported by Deputy Mayor for Health and Human Services Wayne Turnage at the oversight hearing on January 29th, trust in the behavioral health provider network and its faithful delivery of services is at risk. DBH must rebuild community trust by strengthening quality and accountability through significant improvements in its own governance and oversight. DBH certification process offers opportunities to exclude bad actors and more effectively support those organizations delivering high quality services. DCPCA is also concerned about persistent challenges in timely payment of services rendered. Given that DBH eligibility is consistent with eligibility for Medicaid and Alliance, we recommend that DHCF function as the payer. This will improve timely payment and allow DBH to focus on more effective oversight of the provider network. Additionally, providers need an effective process for service authorization with clear clinical criteria and respect for clinical judgment. DCPCA opposes the DBH plan to change its school-based behavioral health program and bring those services in-house at DBH. Students and families need school services that link to organizations rooted in their communities, and we urge DBH to strengthen the current model for school-based behavioral health. DCPCA is enthusiastic about DBH's plan to award planning funds to up to 2 current DBH certified organizations to prepare for their participation as CCBHCs. CCBHC FQHC alignment offers the opportunity to address long-standing disparities in outcomes for people confronting serious behavioral health challenges. As DCPCA and the 7 FQs that comprise the DC Connected Care Network seek to improve primary care and contain costs, we welcome collaboration with DBH and the prospective CCBHCs to meet shared goals. Thank you for the opportunity. I welcome any questions.
Thank you. And on this panel, final is Shannon Walsh. Shannon, if you're speaking, you're on mute.
Good morning. Good afternoon.
Good afternoon.
Good afternoon, Chair Henderson, council members, and council staff. My name is Shannon Walsh. I'm a Ward 8 resident, a licensed independent clinical social worker, and the clinical director of the Core Urgent Care Clinic. The Core Urgent Care Clinic is a partnership between DC Superior Court, the DC Department of Behavioral Health, and Pathways to Housing DC. Each year, the Core Urgent Care Clinic provides hundreds of adults with mental health and substance use challenges with same-day assessment and treatment of complex behavioral health challenges. We support clients who have legal system involvement, co-occurring mental health and substance use disorders, and who often have a history of trauma, homelessness, and incarceration. On staff, we have a psychiatrist, 2 mental health clinicians, a certified addictions counselor, an intake coordinator, and myself, the clinical director. Our office is in a unique position to provide services to individuals regardless if they have an ID, insurance, or residency status in the United States at no cost. We are conveniently located inside the DC Superior Courthouse to primarily provide services to individuals involved in the court, but we can see anyone in the district regardless of court involvement. In fiscal year 25, the Core Urgent Care Clinic staff completed 897 unique intakes, which is 50% above our contract benchmark of 600 and 29% more intakes than in fiscal year 24. Additionally, we conducted 1,078 assessments, 5,747 follow-up visits. In fiscal year 26, urgent care staff are on pace to complete 1,112 unique intakes, which is 85% above our contract benchmark and 24% more than fiscal year 25. We are also on pace to complete 1,444 assessments and 6,344 follow-up visits. This exponential growth illustrates the ongoing and increasing need for this critical same-day behavioral health service. DC's funding of this program has been crucial in being able to provide urgently needed services for our most vulnerable neighbors. This past summer, the Court Urgent Care Clinic provided psychiatric and case management services to an individual who was stranded in the U.S. They traveled to DC to see the museums and learn more about our history, but unfortunately ran out of their psychiatric medication and fell into active psychosis. The trip was supposed to be 3 weeks and turned into 4 months. This individual was utilizing service for housing and obtaining a copy of their passport so they could fly home. Our clinic was able to assist them with medication to stabilize them and case management services to identify options to get them home. We then worked with the individual's family, attorney, pretrial services officer, and the UK Embassy to get them an emergency visa home. This is one example of the important and unseen work that the Court Urgent Care Clinic does to support the health and safety of DC residents and visitors alike. We thank Chair Henderson and this committee for recognizing the necessity of our work and finding funding to continue to do this crucial work in fiscal years 25 and 26. As we shift into budget decisions for fiscal year 27, we urge the Committee on Health to continue to prioritize and expand funding for the Court Urgent Care Clinic. Thank you for conducting this hearing. I'll provide additional written testimony regarding issues with the new Access Helpline procedures. I'm available to answer any questions that you may have.
Thank you. Thank you to this panel of witnesses. Shannon, if you can get that information about the Access Helpline to us in the next 24 hours, that would be very helpful so we can ask some questions about it on Wednesday.
Yes.
Thank you. Ms. Turner, I just wanted to, I don't have a specific question, but I want to express appreciation for your vulnerability and sharing your family's story with us. And the importance of CHAMPS funding, as well as having mental health clinicians in the building. So thank you for being here. Shane, thank you for being here. I think one of the things that we're going to have to talk about in this upcoming budget, particularly with this current administration, is around how do we increase local funding for harm reduction, especially since RFK Jr. and the administration has essentially signaled that they don't believe in harm reduction at all. And there was some confusion about this. Well, there's sort of been this back and forth for the last few months of SAMHSA canceling grants, then pulling them back, then canceling them again, then providing guidance and all of these different things. And personally, I don't want us to be caught in a situation where all of our harm reduction are coming from federal funds. Therefore, when they say, oh, you can't spend money on needle exchange or something else, then all of our operations cease on that front. I don't know if you all have had specific experience with what happened earlier, even this fiscal year, that you wanted to share.
So I know secondhand from folks who are still on staff at HIPS that they've been struggling, like they had to reorient their budget via the funding that they received from SAMHSA. And they could obviously speak better to this, but I know that they are not allowed to conduct syringe exchange under, I believe, the grant funding that was specifically allocated for syringe exchange, and so they had to figure out a different way. So I know it's dramatically decreased the amount of outreach capacity, and yeah, like I said, they can speak more to it, but it's a mess. So that's partly something that I wanted to cover more is that I know HIPS and other organizations are struggling with what you were describing, and definitely need like an infusion of local funding in order to continue operating even at baseline, even though I still strongly think that it should be increased. So
yeah, okay, that's something we'll definitely bring up. Thank you for being here, and I'm sorry for the loss of your friend.
Thank you.
Ms. Goods, your testimony was deeply concerning, and we had a hearing, a joint hearing with the Human Services Committee about permanent supportive housing late last year. I'm curious in terms of the tenant that you were speaking of in your building. Have you talked to DBH? Have you talked to the hotline to get some additional support? Ms. Goods, if you're speaking, you're on mute. are you still with us? Okay, we see you. Okay, maybe we'll come back or maybe not. I don't know. Okay. Hillary, if you're still there, thank you for being here. And I know that this is something that you've brought up quite often around hoarding disorder and
around hoarding disorder and
oh, okay, hold on. Oh, we got Miss well, okay.
we got my well,
Okay.
oh,
Okay.
yeah, okay.
All right, let me go to Hillary. So I just wanted
Let me go to
to
Hillary. So I just wanted to.
Oh, that's not us. That's on your side. I wanted to
that's not us.
ask
That's on your
whether
side.
or not you've had
wanted to
better
ask whether or not
luck
better
working with
luck
DACL or maybe FEMS.
working with DACL or maybe FEMS.
I had a great contact at FEMS after I met Chief Donnelly at an event, and he liaisoned me with the then head of the integrated mobile health team at FEMS. But then when I reached back out to that individual in relationship to this region-wide meeting of the minds coming up next month, he has been replaced, and I have not been successful in contacting the successor person that was identified in the the automatic email, but I am now going to try again copying Chief Donnelly. DACL, DACL does these interventions, but the interventions that DACL they're not behavioral health interventions. They're practical interventions when you have an emergency situation where the condition has reached being a risk to self and others, but it should never get to that point. And even then, when DACL is doing these interventions, it's not behavioral health care. This is a behavioral health diagnosis.
Understood. All right. Thank you for that. Miss Goods, you're back.
Understood. All right.
But I also want you to be safe. So if you could respond
Thank
to the
you.
question.
I can.
Okay. Did
Can
you
you hear me?
Yes, I can hear you.
Good. What was the question? I'm sorry, I didn't hear the question.
Okay, so my question was around whether or not you all had been able to either contact the hotline or speak directly to DBH about the tenant that you brought up. We had a hearing last year with a joint hearing with the Department of, with the Committee on Human Services around permanent supportive housing and some of the interventions that the agencies are able to make when landlords are having issues such as what you described.
We called the hotline. We've not heard back. We left a message for the hotline. We have been dealing with mostly a Metropolitan Police Department because of the alleged drug activity and the number of men that are being let into our building, and also because of the violence when the woman got beat up inside of unit number 7. So we really have been, hired a security company to come in because we have to protect the rest of the female tenants in the building. And we've approached it really from that perspective. When we call NBI, we always notify NBI of what's going on, every incident, every police report, the police are there every day practically. And so we notify them daily of what's happening. The issue is that we can't get, they want to approach it from a mental health perspective, although when you have someone acting in a predatory manner, that's not mental health. That's really, someone exploiting other people who are drugged out, perhaps. But anyway, that's what's being alleged by the tenant when they smell crack cocaine being cooked inside of the unit. So I have left a message for the hotline. I really have tried to work through NBI and through the Police Department. Hotline's more of anonymous sort of, but we do have a name, Dr. Black and Dr. Henderson at NBI, so we have their numbers and call them directly.
So the hotline isn't meant to be anonymous. The hotline is meant to say, we have X problem with X tenant and we need X help. So I will imagine that based on your testimony today, you might get a call from DBH. And if not, we'll certainly follow up with the agency about that.
Okay, I appreciate that. And is there any oversight of the performance standards for MBI that is that the Department of Behavioral Health is implementing? Are there some performance standards and measures that are being used?
They have a variety of metrics in terms of how they do the contracts, not just for MBI, but for others as well. And what you're describing isn't a metric, right? Their metrics are around, did somebody show up for their appointment? How many people did you see? Those types of things. They don't really do, are you having trouble with care coordination and otherwise when someone's out in the community, which is something that has been a concern that was certainly raised by other neighbors and other landlords around how we're doing PSH. Of course, the issue with PSH is that in some ways, everybody thinks that it's a Department of Behavioral Health program when in fact it is Department of Human Services. So we have been trying to sort of navigate those pieces as well. But we'll
That would be
follow up.
wonderful. Yeah. Okay, because I mean, the police and I we're just not qualified to handle the issues that apparently their client has. We just don't have the qualifications. And certainly if there's criminal activity, we have to go and pursue that route, which is what we're doing. Of course, we're filed for eviction already, but the criminal activity has to cease. We can't wait on eviction because, when the children being threatened.
No. I understand. And your testimony about the 6-year-old being threatened. Yes. We're sending an email right now to DBH. So hopefully you'll hear from them soon. Okay.
Okay. Thank you so much.
All right. Thank you. Thank you. I don't have any further questions for this panel of witnesses. Thank you so much for your testimony. Okay. We're going to go to the next panel. Dr. Natalie Smith, Judy Ashburn, Anna Jessiman, Alex Samuels, Sanaya Mitchell, Rachel Ingley, and we'll stop there. So the last panel will at least not be one person. Okay, so again, virtual folks, you have to affirmatively accept our invitation to become a panelist. All right, Natalie Smith.
Thank you so much, Council Member and Chair Christina Henderson and committee members and staff. Thank you for this opportunity. My name is Dr. Natalie Smith, and I'm the founder and CEO of Global Citizens Public Charter School, a public charter school located in Ward 7. Again, thank you for the opportunity to testify today. Mental health is not an add-on for our students, it's foundational. Our students arrive each day with incredible strengths, rich lived experiences, and resilience shaped by their families and communities. At the same time, many are navigating stressors related to community violence, trauma, and unmet behavioral health needs. When those needs go unaddressed, they directly affect students' ability to learn, regulate their emotions, and to fully access their education. Approximately 75% of our students live in wards 7 and 8, and 41% of our students are considered at risk. We currently serve students in pre-K 3 through 3rd grade, and we will grow to 4th grade next year and 5th grade the year after, supporting our young students and young children during their critical developmental years. I want to acknowledge and appreciate the district's commitment to school-based mental health services and the very real workforce and budget challenges DBH is navigating. We recognize the national shortage of licensed clinicians, and we value DBH's intent to serve students equitably. However, I'm here today because gaps in coverage, continuity, and communication are creating real challenges for schools and students like ours. At my school, we have been without a licensed clinician from a community-based organization partner for a year and a half due to a vacancy. During that time, we continue to work in good faith with DBH, completing the environmental scan and waiting for support. Then in late September of this school year, We were notified that due to budget reallocation, schools without an active licensed clinician would be removed from the program with just 1 week's notice. For our school community, this was devastating. What was most concerning was that these decisions were informed by an environmental scan many school leaders believed was a conversation about current challenges, not a process that would determine future service delivery models, and that this information, one of the big challenges, this information was never shared back with our school and other schools, even after multiple requests. Abrupt changes like these disrupt continuity of care, undermine trust, and force schools to backfill services using limited per pupil funds, often at the expense of academics or enrichment. In response, we made the difficult decision to fund an internal school counselor, a critical role that required real trade-offs. To cover this cost, we were unable to invest in additional academic intervention supports, family engagement capacity, and enrichment programming. Even with this sacrifice, one school counselor is not sufficient to meet the level or complexity of need in our community. In a pre-K through in elementary setting, social emotional needs arise frequently and require immediate in-person support. Our school counselor must balance crisis response, preventive programming, teacher consultation, and family communication, all while remaining within the limits of her role. Without access to an embedded licensed clinician, students with higher needs cannot receive ongoing clinical care, and families are often they experience delays or disruptions in support. Over time, these gaps reduce instructional time, disrupt classroom learning, and impact attendance and academic progress. I respectfully urge DBH and the district to share environmental scan data transparently, provide 6 to 12 months advance notice for implementation changes, use a phased and evaluated rollout that protects effective CBO partnerships, continue and strengthen the school-based mental health pilot program, and expand the clinician pipeline through licensure reciprocity with neighboring states. We want to be partners. We understand fiscal realities, but partnership requires transparency, proactive communication, and shared problem solving. Our students, especially those living in Ward 7 and 8, deserve consistent, high quality mental health support. Thank you for your time and unwavering commitment to DC's children. I look forward to answering any questions you may have.
Thank you. Judy?
Hello, Chairperson and members of the council. Thank you for the opportunity to testify. I am Judy Ashburn, Board Chair of the newly formed DC Addiction Treatment and Recovery Coalition, and it's a DC 501c3. I'm also Senior VP at Samaritan Inns and the head of the Behavioral Health Integration Department there. In Washington, D.C., we spend millions of Medicaid dollars each year on mental health and substance use care, yet no single entity is accountable for outcomes, coordination, or cost. Today, behavioral health services are fragmented across dozens of providers, contracts, and agencies. No one sees the full patient journey. No one is responsible for preventable ER visits, failed discharges, or patients falling through the cracks. That's the problem. The solution, we are proposing the creation of a behavioral health accountable care organization, an ACO, anchored by the DC Addiction Treatment and Recovery Coalition. An ACO is not a new provider and not another bureaucracy. It is a governance and accountability structure. The ACO would coordinate care across mental health, substance use, hospitals, and community providers. Use shared data to track outcomes in real time. Hold providers accountable for performance, not volume. Align Medicaid dollars to results like reduced ER use, stable housing, and sustained recovery. This model already works in physical health. DC simply hasn't applied it to behavioral health, where the need is the greatest. Why now? DC is at a tipping point. Emergency departments are overwhelmed by repeat behavioral health visits. Hospitals struggle to discharge patients safely. Providers operate silos with no shared accountability, and the 1115 waiver pause is ending, and value-based contracting is coming. Without an ACO, DC will remain in a reactive fee-for-service loop, paying more and getting less. What the ACO changes. The ACO creates one accountable entity for quality, cost, and outcomes, transparent reporting to DBH and the council, a platform for value-based Medicaid contracts, infrastructure that small community providers cannot build alone. This is how we move from crisis response to system management. The ask. We are requesting startup infrastructure funding to stand up the ACO, not for services, but for data and reporting systems, care coordination infrastructure, governance, compliance, and performance oversight. Once established, the ACO becomes self-sustaining through Medicaid value-based contracts, reducing long-term costs while improving outcomes. In closing, this is not about adding another program. It's about finally creating accountability in a system that desperately needs it. DC has the providers. DC has the dollars. What we lack is a structure that makes the system work.
Thank you, Judy.
The behavioral health ACO is that structure.
Thank you.
Thank you.
Anna? Anna Jessamine? Okay. Alex Samuels? Sanaya Mitchell?
Hi, good afternoon, Chairperson and members of the council. My name is Shania Mitchell, and I'm here to raise serious concerns regarding retaliation, violations of the district personnel manual, gender discrimination, and a failure to apply trauma-informed practices within the Department of Behavioral Health. I began my employment on January 13, 2025 as a state opioid response project monitor with a probationary period scheduled to end on January 13, 2026. I received a 3 value performer rating, meaning my performance met expectations. I was never placed on a corrective action plan, never informed of performance deficiencies, and never provided the required mid-year probationary review under DPM Chapter 14. I am also a union member, and I reasonably expected district policies, collective bargaining principles, and basic standards of due process to be followed. At no time was I given notice of performance concerns or an opportunity to address any alleged issues before my termination. In April 2025, I filed a workers' compensation claim related to an on-the-job injury. DPM Chapter 12 protects employees with medical restrictions from retaliation and affirms their right to request reasonable accommodations. My claim is still active, and my request for support was made in good faith so that I could continue meeting expectations of my role. On December 29, 2025, I met with my supervisor to discuss my annual performance evaluation. I identified errors and requested clarification, which is a protected right. The request went unanswered. On January 12, 2026, just one day before my probationary period was set to end, I was terminated without a meeting, a phone call, or any opportunity to respond. I was notified only by email and mail. When I contacted Human Resources, I was told you were not terminated for cause. That statement is critical. Under DPM Chapter 8, probationary termination must relate to performance or conduct. I had satisfactory rating, no documented deficiencies, no corrective action. The time and follow my workers' compensation claim and my request for clarification raises serious concerns of retaliation. There's also an equity issue. A coworker in the same role who was also on his probationary period received a same 3 value performer rating. It was not terminated. That employee does not share my gender. Additionally, another African-American woman was terminated within the same day, also raising similar concerns. These facts raise legitimate concerns of disparate treatment, Finally, the Department of Behavioral Health promotes trauma-informed care, principles of safety, transparency, and dignity. Abrupt termination without dialogue while managing an active workplace injury directly contradicts those principles and cause significant emotional harm. This is not about special treatment. It's about policy compliance, equity, due process, and accountability. I respectfully request that the council review these practices and ensure that district employees, including those represented by the union, are not penalized for seeking medical care, requesting reasonable accommodations, or raising concerns. I further seek a fair and impartial review of my termination and appropriate relief, which may include reinstatement. Thank you for your time and consideration.
Thank you. Rachel? Rachel Angley?
Yes, thank you, Chairperson Henderson and members of the committee. My name is Rachel Angley, and I am the Crisis Response Team Manager for DC Safe. DC Safe provides 24/7 crisis intervention for domestic violence survivors in the district, serving over 12,000 clients annually. Domestic violence can have a lasting impact on survivors' mental health, and the Department of Behavioral Health is a critical resource for survivors with mental or behavioral health care needs. We are proud to partner with DBH through our lethality assessment program, also known as LAP, and the Domestic Violence System Review Team, also known as the DVSR. While DBH is a valuable resource for all survivors, a strong intentional partnership is indispensable for survivors at highest and most immediate risk. We greatly appreciate the responsiveness and participation in LAP and the DVSR, but we believe that collaboration can be strengthened. In particular, we want to improve survivors' access to behavioral and mental health services while they're staying in our shelter. Housing insecurity is a major source of stress for survivors, and it carries an added emotional toll. However, it's especially destabilizing for our mental health consumers. We would like to create stronger connections to community vendors and DBH staff to enable them to meet clients in shelter and offer critical support in their time of need. More training and relationship building with those vendors and DBH itself can also help us to successfully connect or reconnect survivors with services when their lives are disrupted, as well as build capacity and confidence of behavioral health providers to support consumers experiencing DV. We hope enhanced connections and strong partnerships can reduce barriers and ensure survivors feel supported rather than overwhelmed. Further, we believe there are more opportunities to identify and provide proactive services to survivors in the community through the work of the DVSR. Part of our work in this group is identifying escalated and persistent cases driving frequent 911 calls. While there are absolute concerns about escalating violence in those cases, there are also co-occurring substance abuse or mental health concerns contributing to violence in these households. No individual agency or organization can create successful interventions alone, and we believe strong collaboration can have meaningful impact. We recognize and respect DBH's need to protect consumer privacy, but we do not believe this should prevent a more proactive approach and stronger collaboration with partners. We would love to explore ways to strengthen connections between DBH and DVSR partner agencies that expand access to a wider range of interventions for survivors, especially when traditional pathways have had limited success. We believe there are opportunities to bring sustained behavioral health services more directly to consumers, particularly those with the greatest needs. DBH is uniquely positioned to enhance both crisis response to mental health concerns and collaboration with vendors to build a more trauma-informed and proactive approach to supporting survivors and district residents as a whole. We recognize that expanding and innovating services does not happen overnight. It needs to be both resourced and appropriately and supported politically to have success, and we hope the city can uplift this important work. Thank you for your opportunity to testify today, and we look forward to any questions.
Thank you. Thank you so much to this panel of witnesses. Dr. Smith, lots of folks before you have talked about some of the issues that have been raised with school-based behavioral health, so we'll certainly follow up on that. Ms. Ashburn, I apologize I wasn't able to meet with your group last week because of everything that was happening with the weather event last week. But I look forward to talking with you all more about this idea around an accountable care organization. It's sounding a lot like an MCO, and we got our issues with those, but also in our hearing last week with the Department of Healthcare Finance, we did have a conversation about the behavioral health carve-in going back into the MCO space, and so I think we'd have to think about how that would necessarily interact if healthcare finance decided to go that route. So I look forward to that conversation. Ms. Mitchell, thank you for being here. I don't have the capacity right now in this hearing to sort of follow up directly, but we'll speak with the union. I think we've received the grievance that was filed. And so while DBH will likely tell us that they can't speak specifically about a specific personnel matter, we'll do our best to follow up on that matter because we did receive an email regarding your specific situation separately. So we'll be able to do that. And Rachel, thank you so much for being here and for the work that you all do at DC Safe. I don't have any specific questions for this panel, but if you haven't provided your written testimony for the record, if you could please do so. So thank you all for being here. Okay, we're gonna go to our last panel. Jamila White, Celia Dottridge, Andy Wasnich, Madiana Margot, Ashley Ruff, all right. And we've got one in person. Okay.
Good afternoon, Chairperson Henderson.
Good afternoon. Yes.
Okay, awesome. Perfect. So, good afternoon, Chairperson.
No, hold on. Hang on. It's not your turn yet. Hold on.
Okay.
Yeah, just hang on 1 second. Celia is before you. Celia, are you there?
I am, yes.
Okay, when you're ready.
Thank you. So good afternoon, everyone, and thank you for taking the time to hear my testimony, especially on this long, icy morning. My name is Celia Dottridge. I'm a special education school leader and Empowered Ed Fellow who lives and works in Ward 7. I've been teaching in Ward 7 and 8 since 2014, so I have seen firsthand the increasing needs of our students and families for behavioral health services, particularly post-COVID. I'm here today to testify about the need for reliable, predictable funding for school-based mental health services and investment in hiring and retaining experienced clinicians who can commit to schools year over year. In all my years of experience across different schools, I have never started and finished the year with the same mental health professional. As a special education teacher, I work closely with our mental health support team, as one of their roles is providing behavioral support services to students with IEPs. This means that when I think of school-based mental health services, I am thinking most directly about our students with disabilities who are legally entitled to behavioral support services, as well as their families. Behavioral health service support vacancies means that students across the city are not getting services that they are legally entitled to. But the impact goes beyond that. Families of students with disabilities often require increased support to navigate challenging systems, as well as their own mental health needs. Many of these families carry their own educational trauma and are not quick to trust new faces or new systems. Trust is a key factor in supporting these families. And when our mental health professionals leave after 2 months, 6 months, 8 months, or are not assigned to the same school the next year, then we have to restart the trust building process all over again. Consistent providers allow us to maintain progress across years instead of spending precious time and resources rebuilding every year. The providers I've worked with have specifically named unpredictable funding and job placement as key reasons that they do not stay long-term at schools. My current school, the Riverseed School, is a DC Wildflower public charter micro school located in Deanwood. As a micro school, we rely on per pupil funding, so every dollar for us matters, and we've relied on DBH grants in order to hire and maintain a school-based counselor. Because of our size, we do rely on CBO contractors as we cannot support a full-time position. These services are expensive and would not be accessible to us without DBH funding through grants. And while this funding continues to be available within the budget, the grant process is a challenge, and inflexibility can mean that schools are unable to access the funding. For example, this year, we did not receive as much funding as expected due to difficulties with navigating the process, and did not get this information until well into the school year when we had already signed a contract with our mental health provider. This has had a very real impact on our budget, and we've had to make tough decisions about which of our students and families have access to services, despite knowing that the need is much larger than what we are able to provide. As these gaps between what is needed and what we are able to provide widens, teachers are working to fill in the gaps by acting as counselors and social workers themselves, which is beyond the bounds of our experience and roles. These mental health professionals are a key part of building strong community-based schools. DBH must be held accountable to making sure their grant process is predictable and transparent, and to training practitioners who can stay in roles long-term to build trust with families. Thank you so much for your consideration of my testimony, and I appreciate your time today.
Thank you, Celia. Andy?
Hi, good afternoon, members of the committee. Thank you for hearing my testimony. My name is Andy Wasnick. I am the Director of Policy at Miriam's Kitchen, a homeless services provider located in Ward 2. I am a resident of Ward 4. Miriam's Kitchen's case managers from our meals, outreach, permanent supportive housing, and bridge housing programs have frequent interactions with numerous DBH providers and programs. Today, I'd like to center my testimony mainly about around ACT services and providers. Barriers to service. Individuals who need ACT services are often unwilling and unable to follow the current protocol to get connected to ACT services. Few, if any, when offered the prospect of ACT services, would outright accept it, and fewer still would be able to show up at a provider's office with or without assistance. Community is the C in ACT services. Difficult as though it might be, assessments must be done in the community and not in a provider's office. As the committee is aware, in the past, licensed clinicians working for non-DBH providers had the ability to submit ACT referrals directly. These clinicians or their staff often had long histories with the referred individuals and have greater insight into the individual's needs and history than any DBH provider can assess in an intake. Who better to make the assessment than those who have known the individual for an extended period of time? Community providers need to be able to make these referrals. Another frequent barrier is the individual's lack of insight regarding their illness. The Treatment Advocacy Center estimates that at least 50% of individuals experiencing schizophrenia also experience anosognosia, a prefrontal cortex neurological condition that prevents one from having any sense that one is ill. In these cases, people will outright refuse treatment, especially if it requires seeing a psychiatrist. We must build behavioral health interventions that do not immediately require a visit with a psychiatrist, but that address individual and immediate needs and provide support in other ways that build the trust and rapport that might eventually get the individual to the point where they would accept psychiatric intervention. Too often, ACT teams and others center psychiatry and then use the client's refusal as an excuse to not support or offer services. Trouble assisting unhoused individuals who are already connected to ACT. I was on the Miriam's Kitchen outreach team for over 7 years, and in my experience, providers struggle to serve unhoused clients. The perception continues with our team today. As mentioned above, an individual's reluctance to see a psychiatrist will place a wedge in the reception of services at all. Too often, unhoused clients go weeks or months without being seen by ACT teams, and despite the DHS CSON outreach teams being in existence for 6 years, it is still not standard practice to reach out to outreach teams for assistance in locating hard-to-find individuals. ACT teams, it seems, are reluctant at best to collaborate or respond to outreach teams. And when issues are escalated to DBH, there is often improvement for a short period of time, but it doesn't last. Additionally, ACT teams and all DBH providers need to center an individual's housing status or lack thereof in their treatment plan, and to ensure that their staff at least have a basic understanding of the coordinated entry process, eligibility criteria, and the homeless services landscape in Washington, D.C. And finally, DBH needs to improve the oversight of its many contracted providers, particularly CSAs and ACT providers. A high standard of care needs to be developed and implemented. In addition, we recommend that DBH conduct a rate study and find a way to better compensate frontline staff, thus ensuring better care through the recruitment and retention of talented individuals. Thank you.
Thank you. All right. Mariana?
Good afternoon, Chairperson Henderson, council members, and members of the committee. And thank you for the opportunity to testify today. My name is Madiana Margal, and I am the owner of Red Sprinkle LLC and the founder of Sober and Chic, a peer-led recovery and youth-centered wellness program, which serves communities across the District of Columbia. I'm also a woman in long-term recovery. I'm here today to speak to what happens when a public agency takes a thoughtful chance on innovation and chooses to support vision, not only with funding, but with presence, communication, and affirmation. Sober and Chic was born from lived experience, my own journey through recovery, identity repair, and purpose. But it became a program that, because the Department of Behavioral Health recognized its potential as a culturally responsive, prevention-forward model rooted in creativity, emotional safety, and peer leadership. From the onset, DBH did more than review a proposal. They engaged with the vision. They asked questions. They invited dialogue. They encouraged clarity around outcomes and impact. And critically, they made space for Sober and Chic to be seen as both innovative and credible. That support culminated in my invitation to present before the Opioid Abatement Commission in July of 2025, where I was able to share our programmatic model, metrics, and community outcomes. That moment mattered, not only for Sober and Chic, but for what it signaled, that peer-led, youth-centered recovery work belongs at the policy table. Since inception, Sober and Chic has served over 700 women and youth across the district through empowerment workshops, youth prevention programming, and recovery-adjacent support spaces. Our work focuses on early intervention, offering young people grounding, expressive, and emotionally safe alternatives during critical hours of the day. The outcomes are simple and consistent. When youth are offered dignity, structure, and creative agency, they show up. When recovery is framed as a daily practice, not a deficit, people stay engaged. DBH's belief in this model helped affirm that recovery does not have to look one way to be effective. Today, I want to acknowledge DBH for seeing possibility, for supporting innovation through communication and encouragement, and recognizing that lived experience, when paired with structure and accountability, can drive meaningful systems impact. My testimony is one of gratitude and momentum. Sober and Chic stands today as an example of what becomes possible when public institutions choose to nurture emerging models that reflect the real lives of people they serve. Thank you for allowing me to share this testimony and for your continued commitment to recovery, prevention, and community-centered care across the district.
Thank you. Ashley Ruff. Okay. All right, we have one in person. Next. Just make sure you introduce yourself for the record.
Yeah, that's great. My name is Max Broad. I'm with DC Voters for Animals. I was just following Sober and Chic on Instagram for that. That was great testimony. Councilmember Henderson, I think you might have the testimony with witness list with the most fashionable glasses. It's been fun to see the group here. I'm testifying today about the Green Food Purchasing Amendment Act. This is DC's bill to reduce emissions from food. The goal is to reduce 25% by the year 2030. So we're at the halfway point of this bill. And the in total, there are 7 agencies who serve food. Department of Behavioral Health is one of them. And so what I did was I put together a little scorecard to kind of assess how the different agencies are moving forward. I'm happy to share a little bit about the results of that right now in terms of Department of Behavioral Health. I just want to say at the outset that, I know these agencies have a lot to work with. There are many variables, especially when it comes to serving food. And this isn't to be add another taxing element for them to consider, but, this bill is about preserving our way of life and equity. I mean, when we look at the neighborhoods, our neighbors who are most suffering from the extreme heat of summers or the freaky storms that we had last week, it's our neighbors who have the least. And not only that, in this time, when there's an extreme weather event in another country and it's a country with a poor population that end up migrating to the US or another country that has when they migrate to a developed country, it creates a dynamic that's ripe for authoritarian right-wing populism. So climate change has this direct interaction with our democracy that's really pertinent right now. So I dug into the different agencies that are serving food, and I evaluated them on 4 criteria. One is, are they providing their food purchasing data to DOE to assess? Secondly, are they updating their contracts to include DOE's recommended language with food vendors? Thirdly, are they implementing the steps that DOE recommends, Department of Energy Environment? And then finally, just bonus points to recognize the different steps that a variety of agencies are taking. So on to Department of Behavioral Health. They were recognized for 2 initiatives. They have submitted their data to Department of Energy Environment, and they attended a community of practice meeting where the district's food procurement leads meet to coordinate on how they're moving forward. DOE has some great recommendations for how the agencies can move forward on reducing the carbon pollution from their food. I'm always happy to meet and coordinate with the agency. I'd like to open the door to that to assist them on low lift, high impact ways to reduce carbon footprint of food. Thank you for your time.
Thank you. Hang on one second. Okay. So there are 2 school leaders who said that they signed up to testify, but they didn't receive the link. We sent the link. I'm going to ask questions of the folks who are here. Let's see if the school leaders are able to join us before we end this hearing. Okay. Max, I'll start with you. Thank you for being here and for also keeping up with compliance with this legislation. It sounds like from your analysis, the Department of Behavioral Health is moving in the right direction. But I don't want to put words in your mouth. So
they have taken initial steps, which is great. We're at the halfway point for the law passed in 2021. Its goal is 2030. And they are kind of at the lower end of the pack in terms of progress moving forward.
Okay.
So I'd like to see them pick up the pace.
And what are some things that other agencies are doing better?
Yeah, well, the top recommendation from DOE is to limit red meat servings to twice a week. That's kind of the most carbon intensive food there is.
Okay.
And then making sure that they're serving a plant-based meal plant-based dish at every meal. That there are agencies that are doing that. DCPS is doing a lot of amazing things.
Yeah.
So there's more. I mean, really, the research shows that doing simple things like having fun labels on food, giving them fun names and appetizing names.
Yeah.
Just where you place the food is important. Things like that.
But I think one of the troubles, at least with DBH anyway, is that I imagine that most of their food service is coming out of St. Elizabeth's Hospital, which doesn't really lend itself to fun labels and salad bars in the same way that DCPS or some of the other agencies are able to do. And so that's something we have to kind of think about a little bit. We had a hearing on St. Elizabeth's 2 weeks ago. And there was public witness testimony in the negative about the food that is being served.
Oh, good.
So we can follow up.
Maybe there's opportunity for synergy there then.
Okay. All right. Thanks. Thank you for being here.
Yeah.
Mariana, thank you for being here and telling us a little bit about Sober and Chic. And
No.
Always good to hear about folks having good interactions with the Department of Behavioral Health as a contractor. So thank you for being here as well. Andy, thank you for your testimony about ACT services and the work that we need to do to improve there. Again, this is one of those areas where it's like the intersection between what's happening at DBH and the intersection of what's happening human services, and our need to create more synergies across the board on that front. I didn't know if you had any specific recommendations that you wanted to offer, Andy.
I mean, specifically, like in terms of the referral process, like I think it should go. I think we should find a way for non-DBH clinicians to be able to refer, whether that requires them to take a special training or something like that. Like, I think, if my clinical director, who's a former DBH employee, but if like he's known somebody for a period of time and thinks that ACT services would help them, I don't understand why his, opinion shouldn't be valued the same as whoever is doing the intake at the CSA or at the ACT provider on one day's notice, right? Like, we can send along the history and everything like that. Of course, we can do that. But I think that that would, be really helpful. And, one of the things that a program that, really does seem to work well is the PATH team, who is able to help people who we would like to get connected to ACT, but we aren't able to get them connected to ACT. And so they provide those services. If there's an alternate route here to help folks, with their behavioral health issues, in addition to getting them connected to other services, like that would be great. But the PATH team only has 3 folks on it, right? And so there's only so much that they can do. Like we have nothing but amazing things to say about the PATH team. We think that they're great. It's, and if that is the solution by expanding a program like that, if at all possible, then great. I think, the bottom line is that there are people who are in need of behavioral health supports who aren't getting it because they're not willing to see a psychiatrist. And while that is completely understandable in the medical model and everything, and they may ultimately need a psychiatrist intervention, the fact that we're not helping them with anything, and that is like the deal breaker to service is something that we have to find a creative solution to.
Okay. All right. Well, thank you so much for being here. Just make sure you provide your written testimony for the record. Will be super helpful.
Will do.
Okay. Hold on. I'm going to turn to my team. Okay. Individuals haven't joined us, and I don't have any remaining questions. If you all can just make sure you have your written testimony for the record, I'm going to wind this down for today. So I want to thank all of the public witnesses who spoke. Your testimony is critical to ensuring that the committee understands how DBH is serving residents and its employees. The record will remain open until 5 p.m. on Wednesday, February 18th. If anyone who would like to submit testimony for the record, you can do so. If you weren't able to speak today, go to dccouncil.gov/hearings. Our next oversight hearing will take place on Wednesday, February 5th at 9:30. We're going to hear from the government witnesses for the Department of Behavioral Health. There being no further business before the committee, this hearing is, part 1 is ending. So we're going to recess, and it's 1:35. Thank you so much.